Good morning, bore da, a croeso I cyfarfod bwrdd iechyd Prifysgol Cwmtaf Morgannwg. Hoffwn i estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning, welcome to the Cwmtaf Morgannwg University Health Board meeting. Can I extend a warm welcome to everybody who may be observing the meeting today. And colleagues, just before we start, I wanted to invite us just to reflect for a moment on the impact of COVID over this past year. This was the week, wasn't it, where we reached that horrible milestone of 100,000 people now dying with COVID in the UK. So can I invite you to remember those still suffering from this awful disease today in our health board area, those who perhaps have spent periods in intensive care, and those who have sadly died from COVID. And as we know, these have included some of our own colleagues. We remember you all. Of all the people who died in Wales within 28 days of a diagnosis of COVID, I'm afraid to say that as many as 29% have come from this health board area, and yet we only represent 15% of the population of Wales. It is that all too familiar story, I'm afraid. Once again, the burden of long-term poor health makes our communities vulnerable to whatever comes along. Obesity, type 2 diabetes, cardiovascular disease, and all the rest have for many people a single common root: the poverty which drags down so many in our communities. As we've discussed, our new strategy as we come out of COVID will be to put improving the population's health, the health of those people, and the inequalities at the forefront of everything we do. We will also, I'm sure, colleagues, wish to remember all those families who were unable to say goodbye to loved ones, those in our hospitals cut off from their families for weeks on end, those afraid to go into hospital or seek help, whose conditions may now be worse than they would otherwise have been, and the many thousands who are still waiting for so-called non-urgent care, repeatedly postponed because of COVID. These are all casualties of this disease too, and we remember you all. Finally, colleagues, I know you will wish to reflect on our amazing staff who've struggled on heroically through all of this. They too will have been scared to come into work for the risk it posed to them and their families. They will have cared too for lonely and isolated patients, cut off from those who they love, many of whom subsequently died. And our BAME staff will have faced additional anxieties. During the crisis, many staff, as we know, have moved to work in new and unfamiliar areas and in new ways in response to the pressures on the service. While at home, they simultaneously struggle with all of the domestic issues, such as homeschooling or supporting older relatives. And many are now just plain exhausted. We all, I know, wish to pay tribute to their fantastic team spirit and professionalism, and to their sheer kindness, love, and dedication to all their patients. We thank you all, and we remember those who have suffered. So, colleagues, as we know, due to the continuing restrictions in respect of public gatherings and essential travel, we're broadcasting today's meeting live, so that provides an opportunity for those with internet access to observe in real time using the link which was shared through various channels prior to the meeting. Can I extend a warm welcome to those who are observing us today? And just a couple of specific points that I make each time. Can I just advise those who are watching that we may not always be looking at the camera, as indeed I'm not now, because we'll be referring to our board papers throughout the meeting. It's not because we're not paying attention or because we're being rude. And we will also take a short break in line with good practice at around 11 o'clock and again at 12 if we're still in session. So board members, you will be aware that questions on the consent agenda have been sought in advance of the meeting, which have already been addressed by the relevant officer lead. I don't intend to read them out during the meeting as they have been shared prior to today and have been included for ease of reference under each agenda item within our admin control system, and also shared separately with those not on the system. And in the interest of transparency and openness, all of those questions and answers will be included in the published minutes as an appendix. So some warm welcomes this morning, first of all to Gareth Robinson, our new Interim Chief Operating Officer. Welcome to the meeting, Gareth. And also a warm welcome to Patsy Roseblade, who I think is probably joining as an observer today. Patsy is has just been appointed by the Minister as our new independent member for finance, and she starts on the 1st of March. Warm welcome also, of course, Kathy Moss from the Morgannwg Community Health Council, David Jenkins, independent advisor to the board, and also a particularly warm welcome to Brahms Robinson, Deputy Head of Nursing and Mental Health, who, if they've been able to overcome their technical difficulties, which I hope they have, they will be presenting the patient story, which we'll start the meeting proper with. Also, colleagues, just a slight change in the running order today, if I may. So a reminder that Mark Jones and Steve Stark from Audit Wales will be attending the meeting to take part in a discussion, item 7.3 on the charitable funds accounts and annual accounts. So I'm going to suggest that we bring that item up the agenda and take it immediately after the patient story. And Fiona Jenkins, I know, has to leave the meeting at 11 to join another meeting, but will come back as soon as she can. And finally, a very warm welcome also to Val Wilson, who is our head of midwifery, who will be here to talk with Greg on that particular item on the agenda. So I think that's all the welcomes and the preliminaries, and we can crack on. Thank you. Apologies for absence. I think I've only received one, which is from Councillor Phil White. Otherwise, I think we have a full house. So colleagues, declaration of interest, item 1.3 on the agenda. I'm not aware of any, but can I just now give everybody an opportunity, if there are any conflicts of interests they need to declare in relation to the items on today's agenda, please do so now. Nobody? Good. Thank you very much. Then the first proper item on the agenda is in the patient story. As colleagues know, it's our practice to start all of our board meetings now with a patient story. This is just a very good opportunity, I think, of grounding our discussions in the reality of what it is we're all here to do, which is to provide the best possible care for our patients. And it's really good to hear the good and the less good about the care that real people have received in our hospitals and in our premises. So a very warm welcome, Brahms Robinson, Deputy Head of Nursing for Mental Health, who's going to share the story with us this morning. Brahms, over to you. Thank you.
Can I just confirm that I can be heard?
You can indeed, yes.
I'm grateful for that, if nothing else. Thank you very much indeed. As Chair's explained, I'm the Head of Mental Health Nursing in Rhondda Taff-Ely. I provide clinical support for the team who provide inpatient care within the Royal Glamorgan Hospital. And I want to share with you a story of Bob, who's been with us since August of last year. And Bob is working, living, being working with us in the older persons unit. But Bob's story is an atypical story, and I guess we all have in mind a usual patient on a dementia ward, but Bob is an individual and he's far from usual. Bob's 54 years old. He's born in Rhondda Valley from a large family, and he worked in a family business from the age of 16. He also worked as security in pubs and clubs and was an amateur boxer. He had a large family, supportive family, many children as well. He coped fantastically well throughout his life with an awful lot of trauma, but following the breakdown of his second marriage, He began drinking and using recreational drugs and lost interest in his work. And it's during this period that his family began to notice changes in his cognitions. He did manage to maintain relationships, however, and met another partner who's stayed with him through this period and is hugely supportive of him. He first had contact with us in 2013 when difficulties with sleep and anxiety, but it was in 2019 that we started to see him in the memory clinic. Now, at this age, he's 52 years old, and very quickly he was diagnosed with a frontal temporal dementia. We attempted to support him at home, and he attended our day unit, but only on a few occasions as he found it difficult, the changing environment there. He was admitted to Samhain ward in August 2020 due to his increased agitation and aggression, and he felt that the risk of himself and to others was significant. Unfortunately, as a result of a crisis assessment at home, he was detained under the Mental Health Act. Unfortunately, in terms of the trauma and the concern that causes for the family, though we clearly felt it was the safest thing for him, and the family were very grateful for the support because they were having so much difficulty at that point. When he came to us, as he is now, he's physically fit and able. He's a big man, much bigger than myself, but he's very severely cognitively impaired. At times he experiences hallucinations, visual hallucinations, and he can be aggressive and intimidating behaviours, and that's why family found things so difficult for him. He can sadly be occasionally incontinent and have periods when he's disinhibited, and this is a function of the dementia where the connection with the outside world is fractured. On admission, he couldn't tolerate wearing clothing at times, and he would occasionally enter communal areas naked, and we were very concerned about maintaining his dignity. He often, and still does, often gets frustrated and sometimes refuses to return to the ward. And it was seeing this work that made me particularly think about Bob and sharing his story. I saw the team and the family being so creative in the way they supported him. I'd often find him standing outside the door with the ward doors open and music playing, because we found that as a way to bring him into the ward, to calm him, to make him feel safe again. And that kind of creativity, knowing him and working with the family to understand him, is a line that works throughout the care that we've provided. Slight electronic difficulty, excuse me. Part of the work that we do when we get to know a person is use a document called This Is Me, and that's working alongside the family to get an understanding of someone, his strengths, his weaknesses, what he likes and dislikes. And Bob was described as a strong and handsome man, and he was known as a legend in his community, and he's very well respected in the Rhondda Valley. His family described him, and we found him to be happy-go-lucky, and he enjoys a joke, dancing and singing, music, TV and sport. And I guess one of the considerations around the music and older person's ward is we're all listening to Bill Haley or Vera Lynn. He has a very strong interest in reggae and dance music. It's like the second summer of love, like 1988, big loud music playing at times, and that calms him and provides a lot of levity and calm within the whole unit. He's funny, he's good natured, and he's very, very family oriented. His sister advocates on his behalf, and she was very clear that she did not want pharmacological interventions to manage him. So all antipsychotics were stopped. And this is a medication we will often use in these circumstances, with consideration of the person and the family, to ensure that someone can be calm and can feel safe and be safe within that environment. But we stopped all antipsychotics in conversation with the discussion with the family, and we've worked hard to provide non-pharmacological interventions. And as I talked about, using music, using relaxation, knowing the things that he likes. We look now to prevent these behaviours by meeting his underlying needs for independence, his meaningful occupation and exploration of what's important to him. Knowing him and understanding him and being consistent with him is key to helping him live his life to the fullest. He's a fascinating man. He's huge. He's a massive presence on the ward. There's a lot of joy and a lot of laughter from him. But when he becomes frustrated, things can be very difficult for him. And so we work hard and have worked hard with the family to understand him. Going forward, we look towards always the least restrictive option. And the family, as I said, are hugely supportive. And when we talked about what happens next, where we go from Samhain ward, they were very clear that they wanted to take him home. And so we and them have had to think very creatively about how best to support him, but also to support them. And only over the past couple of weeks, even within the COVID pandemic that we're coping with, we've arranged for the family to come in with full understanding of PPE, and they've walked alongside us to understand how we work with him and how we manage him and how we support him. And they're providing fantastic nursing care alongside us as they develop the skills to support him when he goes home. So when he goes, as he soon will, to a setting where a private landlord has agreed to adaptations in the house, support from the family, a robust package of care and direct payments from regular staff and for the family, with input from both ourselves and from the specialist dementia team, we're confident that we can support him and help him to carry on as he is now. He's 54 years old. We're hopeful for the time he has ahead of him at home and for his family. Thank you, Chair.
Brahms, thank you so much. That was brilliant, brilliant. And as you say, not necessarily a typical patient, but then what patient is, I suppose. Every patient is an individual presenting their own opportunities and their own delights and their own challenges too. Thank you so much for that. That's a brilliant reminder, I think, of just some of the issues which we are dealing with, and the real impact that we can have on people's lives. Thank you very much indeed. Great. Okay, colleagues, we will move on then with the agenda. So item 2 and its various parts is what we call the consent agenda. So this has all been circulated in advance and people have had a chance to scrutinise. Can I ask colleagues then that are there any items in section 2 of the agenda that people wish to move from the consent agenda to the main agenda for more detailed discussion? Nobody's indicating there are, so I can then propose that all members are happy to approve and note the items as requested. Thank you very much. So that covers all of the items in section 2 of the agenda. And of course, as I said before, there will be, we will publish the questions and the answers that people have already had opportunity to raise in relation to all those items. So we move on now to item 7.3, just taking this out of order, but so that we can let colleagues leave and aren't sort of tied down in the meeting for too long. So I'm going to move to item 7.3, which is the Health Board's General Charitable Fund accounts and annual report for the year ended 31st of March 2020. And Steve, over to you. Thank you.
Thanks, Chair. Just a brief introduction. So basically, this is the report and accounts. So it sets out the governance arrangements for the charity and the objectives, and then summarises the income during the year and the expenditure and how those funds were used. I suppose a couple of key features just to sort of draw out for the board is this is the year in which Bridgend came into the health board, so the value of the funds have been enlarged through that. So the total value has gone from 2.2 to 3.1 million. So that's a particular sort of feature. And because of the sort of increased size, the fund has moved to the point where we need a full audit as opposed to a simpler audit. And this is the first year in which we've had a full audit, so there's been a higher audit fee for this year, 38,000. So that's partly because it is a full audit, but also partly because it's the first year and Audit Wales doing a full audit for the first time. So because that's high, we've agreed as a health board to pick up the cost of that. Rather than the charity, if you like, and when it becomes more stabilised going forward, then the higher audit fee will need to be picked up by the charity. So I'll just pause there. I don't know if Mark wanted to come in at this point on the audit opinion on the accounts.
Yes, thanks, Steve. If it's okay with you, Chair, I'll just take a couple of minutes to just touch on some points in our report, if that's okay. I'll start with the main message, which is that we intend to issue an unqualified audit report on the 2019-20 accounts. An unqualified audit report means a clean or a positive audit report. So that's a good outcome, of course. But we as the auditors have to report some issues to you before you consider your approval of the accounts and your signing of the accounts by you as Chair and Steve as the Director of Finance. We then need those signed accounts later today with the signed letter of representation, and it's only when we get those documents that the Auditor General can certify the accounts tomorrow, and he's scheduled to do that early tomorrow afternoon and have those accounts certified. They then go quickly to the to yourselves and to the Charity Commission as well. The Charity Commission's deadline is the 31st of January, so that deadline would be met. Steve has mentioned the impact on the audit, the Bridgend County Borough coming in, so I won't repeat that, but I'll just touch on a few things in the report. Won't take long. There are no uncorrected misstatements, so we draw that to your attention. Where we have found misstatements, the health board or the charity, the charity has made those adjustments. The adjustments that have been made are set out in the report at Appendix 3. There's about 8 or 9 in there. 4 of those adjustments are material, so they're above our material level of £11,000 for this account, but they have been made. We also comment in the report on the higher cost this year, which Steve has touched on, and we do raise one recommendation in the report which management accepts, and that's set out in Appendix 4 of the report. So as I say, subject to your approval, the board's approval, you're known as those charged with governance in accounting terms. As soon as those charged with governance approve the accounts, if you decide to, and sign those accounts, they will be certified tomorrow. Before I take any questions, I would like to thank all officers who helped the audit, and there are many officers in various ways who help us with the audit, but special thanks to Daksha Vasani, who had lots of engagement with us as the main chief accountant responsible for the charitable accounts. So I'll stop there, but happy to take any questions that any members have.
Mark, thanks very much, and thank you, Steve. So, colleagues, we're discussing this in our capacity as trustees of the Morgannwg NHS General Charitable Fund, as Mark has pointed out to us there. So, opportunity, colleagues, for anybody to ask any questions. I know you've all had a chance to read the report, but are there any questions anybody wants to ask or any points anybody wants to make? Yes, Ian, you wanted to come in. Ian Wells, thank you.
Yeah, thanks, Marcus. Can you hear me?
Yes, you're grand. Carry on.
That's great. It wasn't a question, really. It was just a comment. I mean, it was a very pleasing report, I think, right the way through. But one comment, which was on page 4, point 6, and this was a really pleasing thing in relation to the team, because it says you're required by law to prepare accounts, and is of considerable testament to the commitment of your accounts team that you have succeeded in doing so in the face of the challenges posed by the pandemic. And really that's great for our staff, I think. A really good commendation for them. And I just wanted to bring that up, I think.
Thanks,
okay.
Ian.
Thanks.
Thanks, Ian. That's very helpful.
Thanks very much, Ian.
Any other colleagues wish to come in? No, in which case then can I remind you we're asked to do 4 things: to approve the annual report and accounts, to authorise me to sign the report and accounts on your behalf, to sign the letter of representation, and also to note the increase in external audit fee charge. Opportunity for anybody to dissent from any of that. I notice comments coming in to happy to approve, so I take it that we are. Thank you very much indeed. And Mark, thank you for coming along today and presenting what is essentially A bit of good news, I think, isn't it, in the context of everything else we're dealing with. So thank you very much indeed.
Thanks, Chair.
Thanks, Chair.
Thanks, Steve. Good. So we'll return now to the published order of things, and item 4.1, the Maternity Services Programme Improvement Update, which Greg obviously is the executive lead for, but also delighted that Val Wilson is able to join us this morning. Val has been doing, with her team obviously, has been doing fantastic work addressing all the many tricky issues that there are associated with maternity services. So warm welcome to you both. Hand over to you, Greg, I presume, to start with. Thank you.
Thank you very much, Chair, and Val, thank you very much for attending today. We know how extremely busy it currently is within the service, and Val's kindly attended today, Chairman, both to talk through the maternity improvement report, and equally we'll do a bit of a double act with the clinical review response. So if I may, Val, hand over to you first to talk through some of the improvements within the improvement work to date. Thanks very much.
Good morning, Board. Good morning, Chair. Thank you for inviting me today. Yes, just a brief overview based on the report that we've provided from the improvement programme, representing also the neonatal service today in Jane O'Kane, the Improvement Director's absence. So you'll see that despite the immense pressures on the service, we have continued to complete recommendations and improvement works. We currently have 4 recommendations in maternity and 10 in neonatal services going forward for consideration in the next round of evidence review. Still hopeful that we might still get some more recommendations forward for the panel's consideration next month. We have unfortunately, you'll be aware in December that we did need to utilise some of the skills of the improvement teams in the front line. Since the end of December, we haven't had to use the team, so we're back up to business as usual in the improvement team, which is very good. You'll be aware also that the maternity and neonatal improvement plan is now has a much bigger remit, much wider scope than the RCOG recommendations. So although within this report we do very much concentrate on the work that's progressing the recommendations, there's now a much bigger, wider remit of service identified improvements as we move towards that sustained business as usual position, that this just becomes the way that we do things in the services. During December, because of acuity and pressures in the service, we did stand down the formal Maternity and Neonatal Improvement Board. We had an extraordinary meeting of the board members of the Maternity and Neonatal Improvement Board, so we could offer some assurance and receive appropriate challenge around progress and safety of the services. And we met this week to have a full improvement board, and assurances were given as outlined in this paper. We are meeting this week with the IMSOP panel for our pre-meet to have a full review of what we might discuss in the full IMSOP meeting, which is planned for next month in February. We've been working very closely with our corporate colleagues to develop the roadmap, which is a piece of work that demonstrates how we will move through the rest of our recommendations and how we will embed this quality improvement methodologies into our services. We move into a sustained improvement business as usual model, and we're already working closely with the clinical teams to start putting those processes and frameworks in place, adjusting our assurance processes, frameworks, meetings as we also move into the ILG models. So some work going on there to ensure that our reporting processes are aligned with everything that's going on in the ILG as well as through the Maternity and Neonatal Improvement Board. We continue to work on our remaining Make Safe action in respect of culture. The positive feedback that we receive is very, very assuring, not just in terms of that we receive from our families, but also that we receive from those members of our team that are supporting our frontline staff during these challenging times. We're not sitting on our laurels, and in fact have meetings today to look at how we are going to now review the progress in respect of culture and behaviours, and how we're going to move that on as we look to the other side of the pandemic. A lot of work has been undertaken in the last 3 weeks to manage the response, which Greg and I will speak to. Very pleased to receive the first thematic review into the maternal mortality, morbidity category. No surprises, very hard-hitting report to read, but we should be assured that there was nothing coming through that thematic review that we hadn't already identified. Very much aligned to the findings of the RCOG, gave us an opportunity afresh to review our actions to make sure they were nuanced to the experiences of the women, which we were hearing for the first time. But pleased to say that over half of the actions arising from those external clinical review are already completed. So work is well underway in lots of areas. The neonatal improvement team is, the structure is now recruited to, they're working very hard now on their maturity matrices and absolutely aligning to all of the processes that there are currently in place to monitor, measure and assure our processes. Thank you, Chair. Happy to take any questions.
Val, thank you.
Sorry if I may, Chair, just if I can
right.
just kind of finish this off. So yes, so as Val's just described, it's been pretty tough, well, not just within maternity really, but you know, all over our health board over the last several months, and there has been areas of the improvements which we've not managed to quite get on top of. So I'd like to bring board members to key risks, if I may, which is the last page of the report. So there has been a delay in the SI backlog. So this is the backlog that the team were reviewing post October 18, and largely associated to, as Val's described, some of the workforce challenges. Val and the team have just this week recruited to some more resource to support the SI backlog, and we will we had a lengthy discussion about this at the Maternity Improvement Board this week, and we will be working through now. We have some extra bodies on the ground, improvement trajectory to ensure that we clear the backlog and extract any of the learning from that. Again, the culture work's been delayed, and Howell gratefully will be supporting the team now on that work going forward. And as Val described, we have a meeting this afternoon about that. We have had a huge amount of midwifery sickness associated to both COVID and midwives needing to isolate, which has caused extreme pressure on the service, and there have been occasions where we've not reached our necessary levels, although we do have, as described in the paper, a four-hourly acuity audit which takes place on the labour ward with now robust actions for escalation, but there has been on occasions less midwives than what we would have rostered for, and at that juncture, as Val's again described, we've called upon the maternity team to support the service. I think it's fair to say that the SI work is something which has now a big focus on within the maternity team, and some members of the central team are equally supporting that. So just a few risks I thought was important, Chair, just to raise to the board at this point. Thank you very much.
Greg, Val, thank you very much for an excellent report, and I mean, as a health board, we were all deeply shaken by the original RCOG report, the Royal College of Midwives joint report. And I know that everything that you and the team are doing now is absolutely in memory of of what went wrong over those years, and a determination that we will learn and make sure that those circumstances will never happen again. And it's been an incredibly difficult task, and COVID can only have made things just so much more difficult. So it's a massive tribute to you and the staff that you've continued to make progress in these tricky, difficult, long-standing areas and cope with COVID and everything else at the same time. So we're very grateful and owe a huge debt to you, and I know the seriousness with which you take the task as well. So thank you for that. A number of members wanting to come in and make contributions. So Maria, first of all, Maria Thomas.
Thank you, Chair. Thank you, Chair. Thank you, Val and Greg. Can I just say that the team has continued to make improvements despite the pressure of COVID, as you explained, Chair, and the workforce issues that they've been facing, particularly in light of sickness, etc. And the improvement team having to be redeployed into core services. But at the same time, the pressure's been on them around, delivering safe, effective care to the women within their period of service with us, around their birthing. So, tremendous thanks to the team around that. I have to say that I attended the MIB board this week, which I do because I'm the independent representative. And the data that was presented and the run charts, I have to say, are now giving us more assurance, I think, and also helps in the scrutiny of the services than we've ever had before. So Val, I thank you for the development of those run charts, because they do tell us in detail exactly where the improvements are, where further improvements need to be made, and they give us that opportunity to scrutinise as well. So, I just wanted to make that comment. So thank you both very much.
Thanks, Maria. Jane, we'll come to you next. Jane Sadgrove.
Thank you, Chair. I wanted to basically add to what Maria has said. At the Quality and Safety Committee last week, we received a very detailed paper setting out the workforce challenges that the team have had to cope with over the late autumn, early winter. And it was quite salutary. The team has, of course, had to focus on the safety of women giving birth right now, and rightly so. And I thank the team for having done that. Inevitably, as Maria's already said, it's had an impact on the improvement work, because it has had to, because safety has to be paramount. I'm pleased to hear that the improvement work is now getting underway again, and I know that we will have a strong focus on that. We do need to get out the learning, but we also need to give a response to those families, women families that are waiting for the outcome of those investigations. But really want to add my thanks to Val and the team, and to Greg as the lead responsible officer for this work. It is really very much appreciated.
Thank you, Jane. Ian, we come to you next. Ian Wells.
Yeah, thanks everyone, and really I'd sort of add my thoughts to what has been said by everyone else. My question really is related to how we go forward from this point. It was in the report. We've got Appendix 2. We're talking about the 7 remaining RCOG recommendations. I was looking at those, and what I wanted to know really was we don't have any sort of targets or anything against them in terms of time scale, and I appreciate what we've all been through in terms of, or you've been through rather, regarding COVID and so on. Are we in the future going to see some time scales and targets put against those remaining recommendations?
I can respond to that, Chair. So within the report, Ian, thank you for your question. We didn't actually detail the actual actions because it was very much written for families. But what sits behind that is the Maternity and Neonatal Improvement Plan, where each has full suite of actions that will meet the needs of those recommendations. So those are already available within the Maternity and Neonatal Improvement Plan, but we just didn't think it was appropriate to put that level of detail in for a public-facing report.
Yes, thanks very much.
Thanks, Val. That's very helpful. Nicola, you next. Nicola Milligan.
Thank you, Chair. Thank you both very much for that report. I think we all know how much work is going on with maternity and how difficult a lot of the staff are finding it. I think my comment and question is around the key risks you identified, Greg, in number 5 on page 4. And whilst I appreciate the improvement team were deployed, and this would have an impact on the culture work, there is a huge reliance on the maternity improvement team, and I think a change in culture is everybody's business. So I think we need to have some contingencies so that should there be a redeployment again, that work can continue with other members within the maternity team and not just have a reliance on one team.
Can I respond to that, Chair? So absolutely, Nicola, part of the work that we've been undertaking, as previously outlined, is about how we now move the impetus for improvement away from the maternity improvement team into the service. So we are very much focused on service-led improvement. And whilst culture is a big part of what remains to be done, I think the maternity services response to COVID is in itself testament to the change in culture in the service. So whilst the maternity improvement team, if we lose members, it has an impact on our ability to manage the programme. It doesn't necessarily stop the improvement works that are happening within the service. So there is a little bit of distinction there. But the purpose of this afternoon's meeting is very much to regroup as we look forward to being on the other side of the pandemic, to look at, we've got a very different workforce now to that we had a year ago. So what now do we need to do to respond to the ongoing needs in terms of culture, and also to align to much of the work that's going on within the Health Board? So absolutely take those comments on board. Thank you.
Thank you, Val. I just think it wasn't quite clear to me that the work had been ongoing, so that's great. Thank you.
If I may, Chair, great question, Nick. Thank you for that. I think, it was a really tough decision, I think, wasn't it, Val? In relation to, we've got to make sure that our women and families are safe here and now. And as board colleagues will know, our sickness rate, due to COVID and isolation is way higher than what our normal sickness rate is, and generally we can consume our own smoke within the maternity services, Nicola. So if we are struggling with staff around the 5 or 6% sickness, the team can manage. I think with COVID on top of the normal sickness levels, as across all of our services, really, it became really tricky. But absolutely, to progress the conversation around a better contingency going forward, I'm sure we'd all welcome that, Nicola, from all of our services, really.
Thank you, Greg.
Thanks, Nicola. And of course, this is very much an effort across the whole Health Board. It isn't just for those particular staff in that particular bit of it. And Howell, maybe a comment from you would be very helpful in that context too. Thank you.
Thank you, Chair. So just to support what Val was saying earlier on, really. So we have a meeting that Greg mentioned later on today, really just to take stock of where we are on that programme of work. So some of that work did unfortunately have to halt during the initial stages of the pandemic, but some of it has also continued. And as Val said, some of the culture transformation work has carried on despite the pandemic, which I think is testament to those in the service who've been leading that work. We are doing a bit of a reset, having added some resource to the team. So you'll be aware, in my team, we've appointed a new head of OD and indeed an occupational psychologist into the team. So those two individuals will be taking forward some work, working with the service around organisational health and culture. which will enable us really just to get underneath those issues and make sure that we've covered off the remaining actions within the report, working together with the service really. So that meeting is this afternoon, and of course then we'll continue to keep the People and Culture Committee and Quality and Safety Committee fully apprised of that work then as it progresses.
Thanks, that's very helpful. I don't think there are any other questions or comments from colleagues. Val, can I just end really by asking you, you know, that there will be women, won't there, every day who are contemplating coming into our service, and there will be, I know, a level of anxiety and concern, partly because of the historical problems and the publicity that it's received, and simply also because of COVID, because that's a massive factor. Is there anything you would like to say to those women and families who are about to come into our service now?
Absolutely, we absolutely appreciate how difficult this has been for the families, not just COVID, but COVID in a background of, you know, the issues that have been identified. We absolutely appreciate the uncertainty and fear and worry that this must have created. We're working very closely now with our families to understand those concerns. We're working with our CHC colleagues to make sure that our messaging is right, but we're always ready to hear how we can do that better. We really do open our doors to that feedback from our families, but my message would be that we are providing safe services, and that we will take care of you, but if you have concerns, then please make sure that they are heard and we will respond to them.
Lovely, thank you very much. Good.
Thank you.
So no, thank you very much, Val. And so we're asked to note the report, which we do, and note it with some pleasure, I think, really, in terms of the progress that's being made and the determination which is tangible for people to address these issues, many of which, as you quite rightly said, are not yet behind us. There is still a lot to be done. That leads almost sort of seamlessly really into item 4.2, doesn't it? The latest clinical review thematic report from IMSOP. Greg, are you going to talk to this one? Yeah.
Thank you, Chair. I'll just start with a brief introduction, and then Val will go through some of the detail in our response and our work today. But I'd like to first start off, if I may, by saying how very sorry we are for the pain, for the suffering, for the loss caused to those women and families that have been affected in this review. And just a reassurance that we will never ever forget the experiences of these women and families, and will absolutely use these as a legacy to further build on our improvements within maternity services. And I think that's really important, just to, you know, remember that whilst some of these women and families have had experiences, you know, horrid experiences over a number of years ago, we will never forget that, and we will always build on their experiences to progress our services going forward. The clinical review has just two key recommendations. The first recommendation is in relation to the Health Board publishing a response at the same time of the main publication on Monday, which we did, which colleagues have within their board pack today. And the second recommendation is primarily centred on learning, and to ensure that we reach out to the rest of Wales through our networks to ensure that any learning from this thematic review is shared far and wide. And now I'll hand over to Val, if I may, Chair, just to talk through some of the detail of the report, our learning to date and the next steps. Thank you, Val.
Thank you, Greg. I absolutely echo Greg's sentiments. It's been a wonderful opportunity to stop and pause again and consider afresh the impact that our care has had on those families. And what it has given us an opportunity to do is to revisit everything that we'd got planned through that lens afresh. So not only have we been responding to these findings as they've come out, but once we received the thematic review, we've reviewed everything we had planned once again to make sure that we've captured every nuance of what families are telling us. So that's, you know, been a salutary moment really to remember afresh again the distress that families have suffered. We were very pleased with the report in so much of it did identify that we had already identified many of the failings and had robust actions in place. There were a number of actions that were completed. Indeed, as I previously said, half of the identified actions were already completed as part of the work that we'd already undertaken. What was important, I think, were, that we've been able to refresh particularly is around how we're going to engage with our family, and it is part of the progress that has been stopped during COVID. We haven't been able to do the large-scale engagement that we had hoped to do, but the plans are still in place, and we are looking afresh at how we can put those through a different platform, through an IT platform. There are 7 recommendations that are remaining open that relate to this category, and as I've already alluded to, those recommendations already have a full suite of actions with timescales that are addressed to them. We shared our response with our My Maternity, My Way colleagues, and they were very helpful in the co-production of this report, but we will plan to take this now out to our families again to keep refreshing our responses to make sure they're absolutely inclusive of the thoughts and feelings of our families, those that have used services in the past, those that are using services now, and those that might use our services in the future. 3/4 of the cases did have a major finding attached to them. So this is where care, had it been different, the outcome would likely to have changed. And, you know, that's a big number, isn't it? 3/4 of the cases. 19 cases out of the 28 cases. So lots of work. And although, as we say, work is well underway to addressing those factors, we can't forget that figure. Only 1 case in the 28 cases had no learning, and 1 case had wider learning, so not likely to have impacted on care, incidental learning. Of the rest, there was minor learning, so improvements needed, but not likely to impact on care. We've detailed within the report, we've used the 4 themes identified by IMSOP again to reframe how we have reviewed our actions in the past. So we have our recommendations, but as we look to deal with improvements going forward, we are going to reframe them through the themes that are coming through from the IMSOP thematic reports. And that's important because they are based around what the families are telling us the issues were. So that's really important that we keep that focus going forward. We're very appreciative of the work that we've done with our IMSOP colleagues. This is a very balanced and fair report. It's put into the context of the current improvements, but lays out clearly what the failings were and what the work is still to do. And with humility, we accept those findings, and we will continue to work tirelessly to make sure those mistakes are not repeated.
Great, thank you, Val. That's very helpful. Can I ask, before colleagues come in, one question, which sort of goes back to one of the major troubling findings of the original ARCOG report, which is their description of a culture in which staff were afraid to speak out because they felt that if they did so, there might be unpleasant consequences, putting it crudely. We're now in a situation where this is a bit of a test, I think, for us, isn't it? We've got a report which makes some really difficult reading for the Health Board. Can you assure us that we have put behind ourselves any notion of a punitive culture, and that we are now absolutely about learning rather than finding people to blame? Have we moved on in that respect?
Absolutely, Marcus, thank you. Yes, in terms of staff's perceptions of what happens when things go wrong, we have a totally new way of working, and our reporting demonstrates that staff are happy to tell us when things aren't right. There's a confidence in the processes in terms of getting involved in case reviews, sharing learning. We have multiple methodologies now of how we share from cases, how we share learning, not just within the the area, but across the whole service and more widely with our maternity neonatal network, our heads of midwifery advisory group. So people are very much more positive about that side of things. Of course, this has been received with sorrow, and there are a number of concerns. People want to know if they're involved, which is a very different culture to the one I came into a year ago. People are now actively approaching me saying, I'd like to know if I was involved in one of those cases. And we're now looking through, because everything is of course redacted, because the emphasis is on learning. We are moving away from a punitive view of looking at things, but where individuals do want to look if they were involved, then we absolutely should support that they can review cases. Where there are major modifiable cases, we absolutely do track to see if there are particular cases where we have one or more major modifiable factor with staff involvement, and we would then work with that member of staff through identified processes, which again we are reviewing and improving as we move into the depths of the review process. So we work very closely with IMSOP and our HR colleagues to make sure that those cases are managed very well. We haven't yet had a case where we have a member of staff that have been involved in 2 major cases, so that is very reassuring, but we monitor that every time we receive feedback. We go back to our tracker to look at that. So I would say, Marcus, staff feel very confident about the process. There is some residual fear and there is a great deal of sorrow, which I think is the appropriate response to a very difficult read.
Thanks, Val. That's very helpful. Paul Mears, we come to you next, Paul.
Thanks, Marcus. I was just going to follow on from that point that Val's just been making, because Val and I and her deputy and a couple of Greg's senior nursing team had a catch up this week about some feedback on a case they've been dealing with, and it led into a wider conversation about the culture of reviewing incidents and safety. And I have to say, it was really impressive to hear the work that's been done in maternity, and indeed some of Greg's senior nurse colleagues were keen to say that actually maternity is probably leading the way now in some of our approach to creating a safety culture within clinical teams. So I think it's a really great opportunity to actually turn something that's been very tragic and difficult for us as an organisation to have to manage into a positive message now that actually maternity are doing some leading work across CTM in creating a new culture of safety and across a department. And I think I mentioned to you, Marcus, I've asked Val, I think, to come along with some of her colleagues to a future board meeting to bring a couple of midwives with her to talk about the actual bit more detail around this, because I think when you listen to some of the practical things that have been put in place around supporting staff who are dealing with difficult incidents, or have and not just midwives but also obstetricians and others, I think it would be really helpful for the board perhaps to hear some of that detail, because it certainly was very reassuring for me and inspiring actually to hear about some of that work. So I think I would just like to validate I think some of the things that Val said from my own first-hand experience of talking to the team.
Thanks, Paul. And as you say, so important for the future, isn't it, that we strike that balance? That's really helpful. Maria Thomas, come to you next, Maria.
Thanks, thanks, Val, and thanks, Greg, for that. It wasn't an easy read, I have to say, and my heart goes out to those women and to those families that have suffered from this, and still suffering, some of them still. Can I just pick up one issue, Val? You spoke about the support that we're giving to the families, quite rightly so, and to these women. I wonder if you could explain to the board the support that's been given to the staff during the release of this report, and how you've managed and dealt with that. And my other question was around sharing this more widely across your neonatal and your maternity networks across Wales. There's a lot of learning coming out of this, and I think that this would be very beneficial to other health boards across Wales for us to share that learning and to share the outcomes of this with them.
Yes, thank you, Maria. So we've had a staff support package in place for some time now, partly to support staff as we've been going through the reviews and the improvement programme, and then of course we've been able to hugely benefit from the work that the health board put in place to support staff during COVID. So we've developed a very comprehensive support package for staff. We've put some additional hours for some of our midwives in place to be a presence in the clinical area, just to offer support. We have drop-in sessions for the senior team. We have multiple ways that staff can be in touch with us and share their concerns. I've just engaged a senior midwife to do some quite targeted work under the auspice of staff development, but away from statutory and mandatory development. This is about emotional intelligence, well-being, and it will align into the work that we're doing with Hal's team as we move forward. So yeah, comprehensive package, also supported by our trade union colleagues. So you know, really wide ranging, and staff are getting more and more confidence in us as a senior team to bring forward their concerns.
Thank you.
Thanks, Maria. I can't see any more colleagues wanting to come in, so can I thank again Val, Greg, everybody else involved in this. As many colleagues have said, a really difficult read, and I can only imagine how difficult it must be for staff who each day are still trying to provide the highest possible care for women who are in our care. To have to read this, it's very difficult, but that's as nothing compared with the women who are described in the report, obviously. So thank you very much for your continuing work and the seriousness and rigour with which you're pursuing it. Still quite a long way to go, as we know, but good to see the progress that's been made so far. So thank you, Val, thank you, Greg, for that. Colleagues, I'm going to suggest that we take a 5-minute break. It's good practice to get away from the screen and to move your limbs around a little bit for 5 minutes. So I'm going to start promptly at 11:07. Thank you. Right, colleagues, I think it's 11:07. Can we start, Mike? Or
over to you, Marcus.
okay, grand. Right, colleagues, thank you very much. Hope you enjoyed your very short break. We move on now to item 4.3 on the agenda, which is the Targeted Intervention Board update. And I hand over to George Galletti. Thank you, George.
Thank you, Marcus. Colleagues will recall that at the same time we went into special measures for maternity back in April 2019. We were also put into targeted intervention for 3 areas: leadership and culture, rebuilding trust and confidence, and quality and governance. And in response to that, we've put an improvement journey programme together. And the pandemic has had an impact on how quickly we are getting through our improvement, but actually there's been significant progress despite COVID. So the paper in front of you does detail the 3 self-assessment scores that we've undertaken, the first being back in March 2020, which we're classing as our baseline score. We then held a board session where the board collectively self-assessed ourselves at a very high level, and that was in September 2020. There was a tripartite meeting between HIW, Audit Wales and Welsh Government in October to confirm there was no change in our escalation status. But since then, we have done a self-assessment score, now triangulating with our ILGs. So we've done a very strategic high-level self-assessment score. More recently now, we're delving into the organisation and getting self-assessment scores and evidence, working with our ILGs to test whether it's embedding the improvement within our organisation. Colleagues will be aware that we've got a TI improvement framework in the form of a maturity matrix through which the health board self-assesses itself, and we also then provide evidence against that, which we upload onto Objective Connect, which is a secure file share portal that Welsh Government and board colleagues can access. So the last self-assessment scores received in September, as I said before, were received by the board and approved by the board. We're now putting the January self-assessment scores for the board to approve. Page 3 illustrates the scores of the baseline September and revised scores. So you'll see there has been some really good progress in certain areas. The 2 that I'd like to just pull out really are the values and behaviours, which is now level 3. That's largely because our values and behaviours have now been launched. They were officially launched in October last year and are making real headway, being spread out across the organisation. The other area is staff engagement and involvement, also now level 3. We had a very successful staff gratitude event, which took place in December last year with just under 2,000 members of staff logging in to that. We've got a weekly chief exec vlog that takes place now. We have monthly Teams staff Q&A with the chief executive and other executives, and we've established a clinical sounding board. So there are lots of activity going on there to engage better with our staff. Quality improvement is one of the areas that has been impacted by COVID, but we're hopeful that will show further progress over coming months following the recruitment of our Director of Improvement that'll be taking place in the coming weeks. And risk and assurance is another area that I think we will see some progress again over coming weeks. We have just received a reasonable assurance report on risk management systems for the organisation that will be going forward to the Audit Committee in February. So that will be a source of assurance that's quite important in relation to developing that area as well. And as Val touched on earlier, we have got a TI roadmap that incorporates the maternity work as well. That will be shared with the board over the coming weeks and hopefully come back to board in March so that we can share that more widely. Very happy to take any questions.
George, thank you very much. Just a question from me first before I bring colleagues in. Can I just take you to paragraph 2.8, and which you've just mentioned now? I'm particularly interested in the second paragraph under 2.8, which is around staff involvement and engagement. We don't mention here the staff survey results, which on surface seem to me to be quite relevant. A very low engagement with the staff survey, much lower than most other health boards, and quite a few individual results within that staff survey, which would suggest that that staff engagement, trust and confidence is really not where we would want it to be at all. How do we factor in that important bit of evidence in this?
Very valid point, and I think we didn't have the results of the staff survey when we did the self-assessment for this. I know that we've got it later on our agenda to talk in detail about that, and obviously I'll leave that to Howell and other colleagues to comment on, but it will be an important factor moving forward to build into this, and there are lessons obviously to be learnt from the results of that survey, and we've got plans in place to make sure that we look at that in a sort of more finer detail to see where we can pull those areas out and build into our improvement journey. But it is a valid point, Marcus, and I think there is a discussion to be had later on in the agenda about the staff survey, so I won't cover it off here unless anybody wants to come in or Hal has a comment to make.
Okay, I think perhaps it would be absolutely right. It is the next item on the agenda, and we can discuss it there. We might want to reflect back then, having had that discussion about that particular element of the scoring. But we can come back to that later. Thanks, George. That's helpful. Right, a lot of people wanting to come in now. Jane Sackgrove.
Thank you, Chair. I was actually coming in on a related point. You'll not be surprised to hear. I'm coming in both on the values and behaviours and on the staff engagement, and relating the staff survey to the assessment made in both those categories. Marcus has already talked about the staff engagement, so perhaps I'll focus more on the values and behaviours. Looking at the maturity matrix, there are three elements involved in the assessment to take us to that early progress. The first, I'm happy we meet that the values and behaviours have been launched, they're understood by staff, and they're starting to be embedded into systems and processes. I can see that. We get reports at People and Culture about that. The second one is staff feel positive and proud to work for the organisation. Now, if we look at the results in the staff survey, it's difficult to say that that has been evidenced because the figures just don't really bear it out. So I really do question whether we can actually move up from category 2 to category 3 this time.
Want to come back on that, George? Or there's going to be a bit of a trickiness now, isn't there? Because I think we're going to want to talk about the staff survey probably, because it's come on the scene sort of quite late, hasn't it, in relation to this item. I'm wondering whether we should pause this item, move on to talk about the staff survey, which is the next item, and having done that, then perhaps come back to this item. What do you think, colleagues? Does that make some sense? Okay, I know a lot of people have got questions they want to come in on this item, so we will come back and cover all those off. But let's just take things slightly out of order then. Let's pause our discussion on 4.3, and Howell, if you're ready, should we come straight to 4.4 and then we'll come back to 4.3, if that makes sense. Thank you.
Thanks. Thank you, Chair. So I'll just take us through the staff survey report, if I may, Chair, just as I'd intended to, and then we can come back to the conversation then about the maturity matrix at the end. So couple of things just to note, and some headlines I wanted to draw the board's attention to, really. So as you mentioned earlier on, Chair, the one major thing to draw out is really the response rate this time around. So just to give you a little bit of history there, so when we ran the 2018 survey, we had a response rate of around about 18%, which at that point, you'll recall, we weren't happy with as a response rate to the survey. We ran our own survey then in April 2020 and had a response rate of 35%, which benchmarks very well actually across the UK in terms of what you'd expect to see, and for a good data set, I guess, in terms of analysis of a survey of this nature. So we had approximately 4,500 responses actually to the survey response in April 2020. Now, unfortunately, this time around that has dropped down to 10%, with the average across Wales being around about 19%. So we're considerably lower than the NHS Wales average, albeit the NHS Wales average itself is actually considerably lower than where we were in April 2020. There are a couple of things to say about that, I think. So the first of which is the timing of the survey. So the survey was actually run in the first couple of weeks of November 2020, which was around about the time of the fire break, and was at a time when CTM Health Board had considerably higher COVID rates within its hospitals than any other health board in Wales by quite some distance. So that's not to explain away the results, but I think that's just important context in terms of the response rate and people's availability and time to complete the survey in terms of context. However, that said, clearly we aren't satisfied at all with the 10% survey rate, and there are some lessons I think that we need to take from that. We also weren't able to do some of the things that we did in April 2020 to get the numbers up. So you'll recall my team did a lot of work around the health board, actually walking around acute hospital sites, handing out surveys on iPads and various bits and bobs. We weren't able to do that, of course, due to restrictions, and we had approximately 1,500 to 2,000 paper copies in April 2020, just because of the nature of some bits of our workforce finding it difficult to access electronic devices. So again, that was an area where we weren't able to drive up the response rate in the way that we were. Having said all of that about the response rate, we still have 1,500 responses to the survey, so I think it's vitally important that we respect and listen to the feedback that we've had from those 1,500 of our people. And there are some important headlines that I just wanted to draw out, if I may, Chair, in terms of some of the important things that have come out of the survey. So the first of those, I think, is the engagement index score. So that is around about 71% for us. So again, the Welsh average was around about 75%, so it's slightly below the Welsh average on that, but 71% is considered to be a good engagement score if you benchmark across the UK and indeed across other sectors. So I think 71% is a good engagement score. However, it's also important to note that when we ran the survey in 2018 and 2020, it was around about the 74-75% mark. So that has reduced since our previous two surveys. Again, what I don't want to do at this stage is explain that away, and I'll come on to the plan a little bit later on, because I think what we'd like to really do is get underneath that a little bit further and try to understand the results rather than perhaps putting an interpretation on them at this level in an organisation. The other thing just to say is there's been a significant reduction in the survey result around people looking forward to going to work, which is obviously a concern for us. And when you triangulate that with some of the well-being survey data that we've had around levels of anxiety and levels of exhaustion in our workforce, we know that we have an issue that we need to work with our colleagues on around well-being. So that would seem to support and triangulate with the data that we get through our well-being survey. Another area that came out as a particular concern was involvement in changes locally. So staff feeling that they have been involved in decisions that are made at a local departmental level. And again, we have had to make lots of decisions during the course of the pandemic without necessarily going through the same kind of consultation that we would normally in terms of moving people around and redeployments and those types of things. So that has been reflected in the survey. Just a couple of positive elements that have popped out. So despite all of that, and despite the circumstances that we found ourselves in the last year or so, the extent to which people are prepared to go the extra mile still remains very high. That's in the 80s, and that I think is testament to the dedication of our people to the work that they do, even in the most extreme of circumstances and even with the difficulties that we've experienced over the last year. So I think that just is a testament to our staff and their dedication to our population and our patients, which we should recognise. And also there has been a slight reduction in people's experience of bullying and harassment in a couple of key areas, which again is positive. But we mustn't be complacent at all about that, and we must continue our work on that. And there are a couple of bits of work that we're taking forward with trade union colleagues at the moment, being driven at an all Wales level by HEIW around healthier working relationships, which hopefully will contribute to that work. So those are the things I just wanted to draw out in terms of results. If it's okay there, I'll go on to the plan, Chair, if that's okay. So in terms of what we plan to do next, as I mentioned, I think in previous years we might have heard the results at this level and perhaps drawn conclusions from them at this level, and I think there is some danger in that. So we are taking a slightly different approach this year. So we commenced last week some ILG survey review workshops in each of our integrated locality groups, Bridgend, Rhondda Taffili and Merthyr and Cynon, just to try and get underneath the results at an ILG level. We also had a trade union workshop yesterday, which was very, very well attended by trade union colleagues to discuss the results with them and to discuss how we work together as a group really to get underneath and try and make some changes that actually impact on people's experience. And through February, we are organising some team conversations, noting the current constraints, of course, but we are being slightly more creative than we would normally have to be around sessions via Teams, etc. Out in ILGs, just really to get underneath some of the issues that have drawn out, both positive and negative, because there are things that we can learn from both, to really pull together an action plan that addresses concerns. And of course, alongside that then, we are making sure that our communication to our workforce and our people is very clear, so that they are aware that we are listening to their concerns and that we are learning and improving. Alongside that then, on the 8th of February, we are undertaking a values and behaviours pilot in dietetics, which is about our approach then to embedding the values and behaviours work that we've done at a team level. So we've done a lot of the organisational work on values and behaviours, but the work now for us is to make sure that they are embedded across the organisation and fully permeate, and that again is reflected in people's experience of us as an organisation. And I'm pleased to report as well that yesterday we appointed into our employee experience lead role within my team that will work with ILGs to improve the experience of our people across the entire life cycle of their employment with us, right the way from their time starting with us to their time leaving us for whichever reason they do. So that's the plan for us. And then the last section of the report, which is section 5, just talks about some of the leadership challenges around both values and behaviours and staff survey for us then as a group of leaders, particularly around role modelling and ensuring that we are in our own interactions with our people, our various people, taking forward discussions with them about staff survey and indeed values and behaviours. And I'll pause there if that's okay, Chair.
Thank you, Hal. That's very helpful indeed. So, colleagues, we'll continue to discuss this item 4.4 and reach our conclusion, and we'll go back to 4.3. So, are there any issues that anybody wants to raise in relation to 4.4, the NHS Wales staff survey update? And while colleagues are just thinking about that, Hal, can I just take you back to the 10% response rate? I'm not sure I quite understand it still yet. I take your point about the denominator, but nevertheless, any thoughts on that?
Sorry, Chair, do you mean from me? Sorry.
Yes, sorry. Yes, I take all the points you've made, and particularly the points about the denominator. I'm just wondering why we, as a health board, appear to be so far behind comparable boards.
Yeah. So I think as I said, my we've got to be careful to draw conclusions on that and explain it away, and I'm not wanting to do that at all, but I do think we need to recognise the position we were in as a health board when the survey was run. And as I said, in November was a very, very difficult time for us pre-fire break, where we had very, very high levels of COVID activity compared to our peers across Wales. And I think that inevitably will have made some impact. Like I said, I think we need to get underneath that, and actually there are some things that we can do to improve that, so we mustn't be complacent about that. And there are some actions that we can take, and we did take back in April 2020 to get that up to a much more acceptable level, I think.
Okay, thank you. A number of colleagues wanting to come in now, so we go to Ian Wells.
Thanks both. I just wanted to do a few comments on this item. It does actually link to the previous one as well, as you might as you alluded earlier on. In a previous life, I was responsible for surveys in university, and particularly those who worked in universities will have heard the National Student Survey. What we noticed when we did those surveys was that if we had a low uptake, you get a very poor response. Essentially, and lots of people who run surveys note this, you tend to get people who, shall I say, are maybe disgruntled and have got an axe to grind, will fill the survey in. And so you get a very skewed data result as a result of that. Nevertheless, having said that, we have actually gathered the opinions of a section of staff which we need to respond to, and I appreciate what Howell said regarding that, and it's something we have to take on board. I'm glad to see that we've got the follow-on and follow-on in terms of analysing it, because as it stands, the data tells us nothing. All it tells us is we've got a certain number of staff who maybe are disgruntled or don't like something or don't like working somewhere and so on. However, we don't know why, and we don't know what we need to do about it. And so the follow-on, I think, is absolutely vital in terms of trying to analyse really what the problem is and trying to do something about that problem. Having said all that, I think inevitably this links back to the maturity matrix that we were talking about earlier on. We have to take all this on board in terms of the maturity matrix, and what the data we've now got as a result of doing this survey has to be fed back into that. So, as I said, I totally agree with what Marcus said earlier on. I was going to say that before you said it, actually, Marcus, but I think it's important that that actually does feed back into that maturity matrix.
Thanks, Ian. I don't know, Hal, do you want anything you want to say in particular in relation to that, or?
Yeah, I think, note the comments from Ian, and the evidence does seem to suggest there is that skew. But again, we're very clear that actually this is a fair cross section of our staff. So we will absolutely respect the results that have come out of the survey and take those forward. I guess just one other thing to mention is around ILGs. So when the last survey results came about, we didn't quite have ILGs in place at that point. ILG colleagues have been very, very clear and willing to engage in taking this forward locally in terms of local ownership, which has been a really positive step this time around. And again, I think will help contribute to the richness of the information that we gather.
Okay, great. Thanks.
Thanks, Ian. Thanks, Hal. Kieran, we come to you next. Kieran Montague.
Thank you, Chair. I don't think any of us can get away from the fact when we read this report, I think we probably were disappointed. But as someone, like many other people in the room, as friends and family who work for Morgannwg, it is what you hear on a day-to-day basis. So, where you've got the survey results coming back and the conversations you have with family members who work for us or friends, I don't think, we can dismiss what's in the survey, but like Howell said, we've got to do more detailed analysis and fully understand it. But what I would say is a word of encouragement to the team, because I think if you look at the work that we've done as an organisation to put effort into redefining our values and behaviours and the work that we're trying to do around engagement, there's a huge time lag in that actually impacting the workforce, especially a large workforce like we've got. So what I would do is just encourage the team. We have to own where the survey is at and own the culture of the organisation where it's at today, because I think we all recognise it needs to move on, but also recognise a lot of effort and hard work has gone in. But it's probably going to take 3, possibly 5, maybe even 10 years to change a culture in an organisation this large. So what I would say is we have to own. Sorry guys, I can't turn my camera on, I can't work my computer, so I've got some comments on there, and you wouldn't want to see me today anyway. But what I would say is while we have to own the results, I just would want to give encouragement to the team who are doing work on this, because I think we are moving in the right direction. And I think in time that will pay off, but it's going to take a long time, I think.
Thanks, Kieran. We would rather see you, but we accept that we can't. I don't know, Hal, whether you want, there's anything particular you want to come back on there, or should we just take the next contribution?
No, I think I would, if you don't mind. All I would say is thank you for the comments there, and I guess, you know, the plan that we have in place, we still feel is the right plan, I guess, and these results actually, there's a section in the survey about linking these results back to the broader plan that we have around culture and engagement, and not seeing these things in isolation. So we are very much doing that, and while we are receiving some very good positive initial feedback on those things, there is a need for us just to make sure that those embed, as I mentioned earlier, and that will take a little while, but there are also some things that we can improve very quickly as well.
Thanks, Hal. Paul, I think we come to you next. Paul Mears.
Thanks, Marcus. I was just going to sort of reflect back on the point about the response, and I think we were having a chat about this yesterday at our management board, and one of the things we agreed was we almost need to be starting planning now for the next staff survey. Whilst that sounds a bit ironic when we were just talking about the results of the last one, but I think this getting the response rate up significantly, it does take quite a bit of time and effort, and we need to, it's not something we can just scurry around in a couple of weeks when it comes out. We've got to start now thinking about what we can do. And I also think, as Hal says, the ILG structure now gives us a really good mechanism to sort of push this out, but also there's something here about how we use our sort of line managers, team managers, ward sisters and others to sort of help encourage their colleagues. So it's about helping them see that this is a tool to help them understand what's going on within the particular unit or a particular service or a particular professional group. So I think the more we can try and encourage all of those sorts of colleagues to sort of advocate for this, and a key for it will be, well, what's the point of filling it in? So the key thing is to be able to show why we want to do this, and how we perceive that it's an important part of understanding how staff feel about things and how we can make improvements. So I think there's a lot we can do, and frankly, you know, even the Wales average of, is it 18%, I would suggest isn't a particularly bold aspiration for us to achieve. So I think, you know, we should at least be aiming for 50% or something like that, which I think might be a good starting point to set ourselves a challenge for this coming year. There you are, I'll set the challenge. I know.
Super, Paul, and that's in the minutes. Excellent. Thank you very much. Good. We are slipping back into jargon, colleagues, aren't we? And apologies for not picking this up before. ILG, we've spoken about several times, Integrated Leadership Group. So those are the three elements, the management
locality groups.
Yeah.
Locality group, Marcus.
Locality group, sorry. There we go. Yeah, that's a salutary lesson from me as well. Thank you very much, Paul. Good. Thank you. Next on my list is Maria Thomas.
Thank you. Thank you for that. My question was around the recommendations and the governance arrangements for reporting. There's a lot of analysis and engagement to go forward with the plans that you've suggested. And I'm just wondering whether, as part of the recommendations that you're asking the board to note, is the arrangements for where this will be reviewed and look to the improvement plan. Will that be the People and Culture Committee?
Absolutely, yeah. So there's a couple of things just to note on governance around this and values and behaviours actually in our wider employee experience work. So our new head of OD, Sharon Nash, one of the things she identified pretty quickly, having started with us in January full time, was the need for some more robust governance on those pieces of work. So she has proposed a governance route for these things to be managed effectively with key stakeholders that will then report in via the People and Culture Committee. And Jane and I, obviously, because our committees currently aren't meeting due to the pandemic, have already had a discussion about that separately. But that will more formally then report into the People and Culture Committee.
Thanks for that. I think it would be helpful if we could put it into the recommendations as well.
Sure. Yeah, no problem.
Thanks, Maria. Nicola, we come to you next. And I know, Nicola, your question sort of straddles 4.3 and 4.4, doesn't it?
It does, thank you, Chair. I think firstly, just to pick up on a point that Howell made, and despite a majority of our staff feeling exhausted, having their own well-being issues, 86.4% said they would go that extra mile, which just goes to show how they always put patients and communities first. And I think that absolutely needs to be recognised for the staff out there. But my point was around the maturity matrix, and Jane has touched on a little bit of it. With our engagement and involvement, we show that we've moved up to level 3, but if you look in the narrative, Howell, of the staff survey, it says that there's a 5% decrease in the overall engagement score. So that doesn't quite fit in with what we're showing, I think, on the maturity matrix. And with the values and behaviours, if we look in Objective Connect, we've got all 3 ILGs showing level 2, but the maturity matrix have moved up. And also in Objective Connect, the employee experience, all 3 are showing a basic level. So I'm just, that Objective Connect and our staff survey doesn't quite seem to fit in with what we're saying the progress is being made on our maturity matrix. So I just think, and I appreciate it just says proposed score for January, but maybe we just need to re-look at our maturity matrix and where we actually are sitting.
Right, yeah, I mean, so George may wish to come in on this as well, but I guess there's a couple of things for me. So I think the engagement element of the maturity matrix contains bits of information about other areas of work which are under the umbrella of staff engagement but are slightly different. So I take your point completely about the score having reduced from around about 74, 75 down to 71. But that is one element of that. So I don't know whether George wants to come in on that.
Yeah, by all means. So yeah, the examples that I referred to earlier are the sorts of things that under the banner of staff engagement involvement within trust and confidence of targeted intervention is around what we're doing to make sure that we provide opportunities to engage with our staff. I think how the staff survey has been measured around staff engagement is coming at a slightly different angle. So the examples I used that we've self-assessed ourselves against are, we've held a staff gratitude event and we had nearly 2,000 members of staff engage with that, which is a first for us. We're doing a weekly chief exec vlog, which is a new thing that we can monitor the hits on our Facebook pages and our website to see how many people are accessing those. So we've got those sort of measures to show that people are engaging with us within those sort of areas. And I just think that maybe the staff engagement within the staff survey is looking at it from a slightly different perspective. But needless to say, our assessment needs to now take account of the staff survey results that we didn't have at the time we undertook this self-assessment. So I think it's vitally important now that, yes, we've self-assessed ourselves against what we believed at the time. This adds a new layer of information and a wealth of evidence that we need to now just sit back, assess and reevaluate.
Thank you, George, because I think that'll pick up on Howard's point where we have to value the feedback we've had, albeit a very small amount of staff, but if they've taken the time to feedback, we need to take that into consideration.
Great. Nicola, thank you for making the point about 86% of staff would go the extra mile. I mean, that is a fantastic, well, tribute, recognition of, you know, what we know to be the truth, that, you know, our staff really, when push comes to shove, they can absolutely be relied upon and they will go that extra mile. You know, thank you for raising that.
Thank you, Chair.
Thank you. Jane, we come to you next. Jane Southgrove.
Thank you, Chair. And fully support what George, Howell and Nicola have just said about the need to triangulate with this new information that we have. We've done an awful lot by way of initiatives, lots of inputs, lots of change that we're seeking to introduce. but we have to also evaluate whether it's actually making a difference for the people on the ground. And we know that culture change and the like takes a long time. It obviously hasn't hit home at the point that this survey was undertaken. Second point I wanted to make really was around the two levels of results that we have in relation to the first two questions. I'm proud to tell people I work for my organisation and I would recommend my organisation as a place to work. In the overall results, we're up at about 55 and just around the 50% agreeing with those two statements. But let's look at the ILG position on those two, which I take it really removes the corporate staff from the equation and really focuses on the views of the frontline staff. And there we have much reduced scores, particularly in Rhondda Taffili. And I think that really, for me, underlines the need for us to review what's going on in the various parts of the organisation, what action plan we need to put in place, as you've described, Howell. And I think we need to be sharing those action plans with staff, giving them feedback on progress, not just once a year, but perhaps by some sort of web presence which says what sort of progress we're making against those, for that to be updated regularly and for us to remind people of the progress that we're making. And it's only by building that trust and confidence with staff that we can aspire next time we run a survey that more staff actually feel it's worth completing it, that it will make a difference. That's all I wanted to say. Thank you.
Thanks, Jane. I don't know, Howell, do you want to say anything in relation to that?
Just to agree with everything that Jane has said there. Thank you, Chair.
Good, thank you. And Mel, we come to you next. Mel Jaggy.
Yes, thank you, Chair. I think this is one for George. And if I may, Chair, can I go back to the target intervention on 4.3? Because it links into some of the observations that I've seen in the staff survey. It's going back to the one area where we don't seem to have made any progress whatsoever. Because we're still on level 1 basic, and I think it's one of the most important of the categories under leadership and culture, sorry, and that's inspiring a shared purpose within our organisation. And I'd just like to know what the obstacles are, because when I'm seeing things like I'm enthusiastic about my job, I'm happy to go the extra mile, and I'm proud of the organisation I work for, I'm a little bit bemused that we don't seem to have developed and gone up at all in relation to that objective of inspiring shared purpose. So I'd just be interested in other obstacles and why we can't improve.
I noticed, Paul, did you want to come in on that specific point there, Paul?
Yes, thanks, Marcus. I think, Mel, probably this reflects a bit of the feedback we've had from members of staff, particularly clinical teams, about lack of clarity about where we're going as an organisation in terms of our strategy. And I think this is probably a reflection of people feeling that they, having a shared purpose and a shared sense of where we're going as an organisation. We've been through a lot of change over the past couple of years with the Bridge End boundary change, a new structure being put in place last year. I think, as we said before Christmas when I gave my feedback on the 100 days plan, I think the one thing we're now at the point of, we've made some of those structural changes around things. Now's the time to actually really clarify for our organisation, be clear about where we're going in the future in terms of our model of care that we want to see in place, the clinical services that will sit, how we'll design our clinical services to meet the needs of our population, the focus on out of hospital care and population health. I think all of those things, if we're able to articulate that much more clearly and crisply, if you like, to our colleagues across the organisation, it will help them understand where we're going and hopefully then sort of fit that point of a clarity of purpose for everyone in the organisation, that we're all pulling towards the same end point. And I think that's got to be the priority now for the next year or so.
Yeah, Chair, if I can make an observation on that, because we speak in a great length about staff engagement, I like to speak more about staff involvement, and that be a theme, because I'm conscious of some of the lower scores that we have in our survey about people feeling that they're not involved in decision making in their workplace. So I think that there's a little bridge that we can build there, so that staff involvement becomes just as important as staff engagement. It's just something I'll throw in from a past experience. It's so important.
No, I think you're right, Mel. I think that plays into, as we're developing our thinking around strategy, not just at a macro level for the organisation, but also then individually in localities and in individual teams. It's really important that people understand, you know, what we're trying to achieve as an organisation and what does that actually mean for them in their team and in their role, and how can they help shape what we're trying to do. So I think for us it's about setting the overarching framework where we need to go as an organisation, and then working with clinical teams to work out, well, what does that mean for you within your service or your specialty. And I think we're also having some conversations at the moment about how we can bring a much more significant clinical voice into those conversations, about looking at developing a sort of a clinical forum that sort of sits on a par with the management board, so that actually we've got a lot more opportunity for clinicians and people across the organisation to input into some of those key strategic decision making, because I think that it goes back to the point about cultural change, doesn't it? This is about trying to create a culture now across the organisation where people do feel they can say it, because I think part of our challenge is people have got lots of ideas, but perhaps have felt previously it wasn't their job to sort of give their idea, or they put forward an idea or suggestion and it hadn't been listened to, and so they've given up trying. So we've got to, it fits back to the point earlier about the values and behaviours, about we're all one team trying to achieve an improvement in the health and care of our population, and it's trying to balance that with the operational realities of getting people to feel comfortable with putting forward their ideas and suggestions.
Yeah, I agree, and I still think it's so important that we all know that our staff and all our personnel do great work, but it's also important that they feel good when they're doing it and they feel involved in what they do as well. So thank you all for your responses.
Thanks, Mel. I don't think any other colleagues want to come in on this point, and we're going to go back to 4.3 in a minute. So let me just sum up that discussion then. First of all, thank you. That was a very rich discussion, actually, wasn't it? And absolutely as it should be, because this is such an important source of information, which, as you say, Hal, we need now to dig beneath the surface and understand it. But the last thing we must do is explain it away, exactly as you've said. I remember, is it the managing director of John Lewis saying the most important thing that John Lewis ever does is its staff survey, because so much for that business depends upon that. And anybody with background in universities will know, you know, the National Student Survey, boy, does that matter as well. So that for slightly different reasons probably there. But yeah, this really is important, and it's encouraging to see how seriously we're taking it and following this through. But it does give us cause for concern, doesn't it? Because on the surface, this is definitely not what we want to be seeing, and we need to understand what that means. So thank you very much. We're asked to note the report, and we've also just talked about how the People and Culture Committee will be following this through as the plan pans out. So that's very helpful too. And the idea of starting to plan now for next year seems to me to be absolutely eminently sensible. So thank you very much. Thank you, Hal, for that. So colleagues, let's go back then, having now had that discussion, to 4.3, the targeted intervention programme. And I made a little list of people who wanted to come in. Now I know we may have, their questions may have been overtaken by the discussion we've just had, but I'll just go through and make sure that that people have had answers to their questions. So Mel, you were the first I had down under 4.3. Is there an additional point you wanted to raise, or has it been covered?
No, there's not, Chair. That's fine, thank you.
Super. And Ian, I had you next on my little list. Ian Wells.
No, I did mine earlier. Thanks.
Thanks, great. And Maria, you were the last one I had down on the list from previously.
Yes, thank you. Just one question, George. It's around you say in the key risks that there's a risk that the TI arrangements remain on a light touch basis because of the fact that the place that we find ourselves in COVID. I'm just wondering, from a Welsh Government point of view, and Paul may want to come in on this, what has been the discussions with Welsh Government around possible slippage around some areas because of the effects of COVID?
I'll come in on that, Maria. Yeah, I had a meeting this week with Andrew Goodall and his team, actually to sort of give them the feedback that I'd given board members on the 100-day plan. And in some ways, they felt it was a helpful sort of way of also sort of, whilst we haven't got a formal TI review meeting at the moment with them because of the current pandemic situation, it was a useful opportunity to also cover off quite a few things which come under the banner of TI with them. And we did actually highlight to them some of our perspectives on the maturity matrix as well. Andrew is quite keen, and I think, you know, the stat, aside from TI, the general joint review meetings that we usually would have with Welsh Government as health boards across Wales haven't been happening because of COVID. But Andrew suggested earlier this week that, you know, he was very pleased to see some of the things that we were doing, pleased to see the progress, and he was keen to see if we could find an opportunity, even if it's not a hugely onerous meeting, to have a sort of a jet meeting with our exec team and the exec team from NHS Wales to go through some of the things we're working on, because I think that there was a recognition that the risk of not having the meeting is not just about the things that they might not see progress on, it also denies us the opportunity to showcase the things that are going well. So I think we're in conversation with them at the moment just about that, and whether that may be something we'll move forward on over the next month or so.
Okay, thank you, Paul.
Thanks, Paul. Unless I've missed anybody, I think that covers all of the questions that that we had. I'm just checking the chat line, but I think we've covered it all. So, George, going back then to what we're asked to do, it's to approve the self-assessment scores. I think, cutting to the chase, we're not absolutely sure that we're prepared to do that in every single regard. Particularly a couple of those things that we've discussed under paragraph 2.8, and that's essentially because the staff survey has come along late in the day, hasn't it, and has given us pause for thought, I think, really. And given self-assessment is always a tricky thing, I think if you're assessing yourself, you should always be hard with yourself and make sure you're absolutely sure about what you're saying. So I think what we're saying, George, is that we would ask the team just to have a look again at some of those and make sure that in the light of the staff survey that we're still confident that we can improve a couple of those key scores. How is that? Does that make sense, George?
Thank you, Chair. I think that's eminently sensible, because the three areas really that we were suggesting we could potentially move up prior to receiving the staff survey results all relate to staff engagement or staff involvement or staff experience. So I think that's eminently sensible. We'll take it away, have a relook. In the meanwhile, we do have to agree a position. So could I just ask if we're comfortable to reinstate our self-assessment score that we reflected back in September for now? And then, as I say, the only three areas really that we were suggesting we could have possibly gone up are those three, which we need to look at in light of the staff survey.
So just to clarify, then, we're saying what we might now be saying is that the assessment in September 2020 still applies. Is that what you're suggesting, George?
I think that ought to be our default. Yes, please, Chair.
Good. That makes eminent sense to me. I'm just having a look at the chat line to see whether anybody dissents from that. Anybody wish to come in? No, I think that commands everybody's support, George. Thank you very much. Good, thank you. I'm going to propose then that we take one more item before we have another quick break. So we're going to move on to item 5.1, which is the COVID-19 pandemic response from Kelechi. We'll take that, we'll have a short pause, and then we'll talk about vaccination. So we'll separate out those two COVID-19 items. But Kelechi, over to you. Thanks very much.
Thank you, Chair. Good morning, everyone. I think, Mike, what you're going to thank you. So as usual with this, because of how quickly things move with this pandemic, I tend to give these presentations to make it as the information in there as recent and relevant as possible. So bear with me in terms of using a PowerPoint set of slides. So if we move on very quickly to the first slide, I haven't made any, I haven't included anything in relation to vaccination here because we're going to cover it as a separate but related item. So I'm going to focus for a moment on recent trends in COVID infection in CTM communities, and I've consciously separated out the data for the 3 local authorities that I'll run through very quickly on the next slide, starting with Bridgend. So the data here is the trends from early September right up till the present moment in terms of daily infections in Bridgend. And what we can see here is we are very much, I think, into the 4th week of consistent reduction in the daily infections. We had that post-Christmas spike, but since then, it's been a very clear downward trend in daily infections. On the next slide, we see the rate of positivity of every COVID test done in Bridgend, again, tracking from early September right through to recent times. And again, you can see that post-Christmas spike, but since then, the positivity rate of COVID across Bridgend has been a very consistent downward trend. And then the next one then looks at the 7-day cumulative COVID infection rates per 100,000 population in Bridgend, tracking it from mid-September right through late January, and a very clear post-Christmas spike. But after that post-Christmas spike, it's been a consistent reduction in infection rates per 100,000 in Bridgend. And then on the next slide is again tracking testing uptake, which is an important consideration where we're seeing a reduction in numbers of infection. Are we seeing those reduction in infections in a way that reflects the reality, or could there be important caveats here? And my point is that there is perhaps an important caveat, because if you look up in early December, late November, early December, when we're getting a significant spike, there was an increase in testing uptake. But pretty much since then, the trends in uptake of testing in Bridgend have been downward. So I think whilst we're looking at a reduction in rates of infection, I think it's important to bear in mind that that could well be explained by the fact that we're getting a reduction in testing uptake. I think my sense is that it might be a factor, but it isn't a significant factor. I think the reductions in infection we're getting is a genuine impact of the restrictions or lockdown that we have been on since 23rd of December. The next slide then focuses essentially the same data on Merthyr, but one of the things I wanted to pull out in Merthyr is that whilst you could see a post-Christmas spike in positivity rates, daily infections and cumulative infections in Bridgend, and we'll see that to a lesser extent in our city, it's almost non-existent in Merthyr. In Merthyr, what we had was that spike which coincided with the peak of the second wave. But since then, it's been a consistent reduction, and Merthyr did not get the post-Christmas spike. Our hypothesis is that that had a lot to do with the whole area testing that we did in Merthyr and then in Lower Kynon. But we're going to, I'm going to include a few slides just to reflect on that. On the next slide, we see the positivity rates for infections in Merthyr again. Since the peak of that first of the second wave, it's been a consistent downward trend in positivity rates in Merthyr. And then on the next slide, we see the 7-day cumulative rates again, very different in terms of the epidemic we saw in Bridgend and what we will see in our city, with the second wave just being the only peak, if you like, that Merthyr experienced in that comparable period, and which we think is down to emphasizing the importance of the whole area testing that was done in Merthyr as an important potential explanatory factor. And then on the next one, again, is the testing trends. Again, we see that reduction in testing uptake since December. And that is an important caveat that I think it's important to bear in mind. And the regional Test, Trace and Protect program obviously has recognized this and doing a lot of work through our partnership and comms, just to raise awareness around testing, so that people don't assume that because infections are reducing, then I do not need to go for testing. It's important that we keep on testing, because that's an important way to put an end to the pandemic. And then the next couple of slides will essentially repeat the same data for RCT, so I won't talk in detail about it, but we see the peak and the reductions in daily infections. Next slide, consistent reductions in positivity rates. Next slide is the reductions that we're getting in the 7-day cumulative infections. You could perhaps suggest that the rate of slowing is probably slowing down, if that's isn't too complex a use of words. And then finally, on RCT, we see the next slide, the same pattern of reductions in testing uptake. That I think the key message here is that we are in a good place in terms of community infections. The lockdown is working. The rate of infection has been going down. We're very much in the 4th week of a consistent reduction in community infections across the patch. But it is absolutely important that we give sufficient time for the restrictions to bed in and reduce the rates of infection to as low as possible. And then with population immunity setting in, both by reason of natural infection and vaccination, which we're going to cover in a moment, then that gives us a chance of suppressing any likelihood of a resurgence whenever the lockdown is lifted. On the next slide, then is looking at recent trends in COVID infection in CTM hospitals. Again, the hospitals, as you probably know, have had outbreaks in recent months, and we don't have high walls around the hospitals. They absolutely reflect what's going on in the community. So with the reductions we're getting in the community, we're also seeing a reduction in the rates of admissions into the hospitals from people acquiring COVID in the community. So it's a downward trend, and the data you see here is just describing a 2% daily reduction in the rates of admissions with COVID from the community. The next slide is essentially the same data, but this time in relation to critical care admissions. Again, it's a downward trend in the last 2 weeks. The next slide is looking at staff testing and positivity. And this is very important, because you remember during the onset of the outbreaks that we had in the district general hospitals and community hospitals, we were very mindful of the positivity rates we were getting amongst patients, but also the positivity rates we were getting among staff. And the good news here is that if you look at the 3 integrated locality groups, you can see Bridgend, Merthyr Canon, and Rhondda Taff Ely. And you can see on the first column, on the leftmost column, the percent who are newly positive, and in the middle, numbers tested, and then in the right-hand side, incidents per 1,000 staff. And you can see a downward trend in terms of percent positivity and incidents per 1,000 staff. That's almost negligible now in Bridgend, Merthyr Canon, and to a slightly lower extent in Rhondda Taff Ely. But that is just displaying a very, very positive picture. And the next 3 slides will be very familiar with the board. This is setting out for each of the district general hospitals, looking at the trends over a period of time. Since late last year, when we started having those outbreaks in the hospitals, in terms of the patients positive cases and the staff positive cases. And more recently, you could almost look at this almost as a picture, as corresponding picture with the community infections. So this is Royal Glamorgan Hospital, both staff and patients tests, and it's a decreasing number. On the next slide, we see the same data for Prince Charles Hospital, and again, it's a very, very clear downward trend. And then on the next slide, we see the picture for Princess of Wales Hospital, again, a very clear downward trend in the last 3 to 4 weeks. Okay, and then on the next slide, I apologize if I seem to be moving too fast. I do recognize that a lot of the detail we have here is something that many board members will be very familiar with. So, but I'm happy to take questions if there are any areas I need to go over. I wanted to include a bit of reflection on the whole area testing in Merthyr Canon, in Merthyr Tydfil and Lower Canon. As you remember, we ran this whole area testing, and the full evaluation is still afoot, but the working group has written an interim paper that has informed Welsh Government policy around community testing. So I just wanted to pull this out. So between 21st of November and 18th of December, we did the whole area testing in Merthyr Canon, and you can see the centers that we used. And then on this next slide is essentially the same data for the Lower Canon and the sites we used to do the whole area testing. And then on the next slide, an important variable finding in terms of testing uptake, we eventually described this in the loose words of the inverse testing law, where there was a very clear socioeconomic gradient in the uptake of testing, with more deprived populations less likely to take up testing. But then when you move on to the next slide, you also see that inverse relationship and that socioeconomic gradient. More deprived populations are less likely to take up testing, but when they do, they are more likely to be positive than less deprived populations. That idea of the inverse testing law was a very clear and very compelling finding that is informing the approach we're going to use to community testing going forward. And we're having a conversation later today to devise a plan in response to an impending Welsh Government strategy on community testing, which, as I said earlier, has drawn quite a lot from the whole area testing pilots that we did in Cumulative Morgannwg. On the next slide, these are the remarks and recommendations. So we did say very clearly that as far as lateral flow tests or lateral flow devices are concerned, we think that there is a very clear public health role for community testing using LFT. We think it should be targeted at three specific kinds of populations or settings. One, more deprived populations, and two, local industries in hair and beauty, manufacturing and transport sectors, essentially shorthand for occupations where the human contact density is likely to be greater, and then deploy them in periods and places of temporal increases in incidence. In this context, from some of our whole area testing, we were very clear that the use of confirmatory PCR should not necessarily continue in some of those settings, and that contact tracing should not wait for a confirmatory PCR, but should be initiated on a positive LFT. These were things we tested in our pilot, and they worked to great effect. Particularly when deployed in the first two settings, adequate support should continue to be provided to enable people self-isolate on a positive LFT, and this is one of the central objectives of our Protect workstream. I'll move on to the next set of slides. I think that will be the end. I think I've just got two more slides and I'll stop, and that is a moment to pause and reflect. The chair made reference to at the start of the meeting to the fact that CTM, if you could look on the next slide, I think CTM represents 15% of the Welsh population, but somewhere between 22 and 25% of the overall mortality in Wales. So we are proportionately, or rather disproportionately affected by COVID. And that must tell a lot about the degree of physiological resilience and predisposing risk factors, not only to acquiring COVID, but also to experiencing adverse effects from COVID in our population. And it is something that I know we have been reflecting on and thinking about what we need to do and what we need to be, not just as a health board, but as partnerships, whether it's the public services board or whether it's the regional partnership board. What do we need to do and what do we need to be in terms of our working with our communities to ensure that we are able to tackle the risk factors, that the underlying risk factors that have resulted in the sort of data we are looking at, because people are now talking about the new disease X as the new pandemic or the future pandemic. There's a lesson for us in terms of what do we need to do to modify the risk factors that have predisposed our population to this sort of adverse outcomes. I think on the last slide, this is just describing what we already know. The deep blue line there is describing all deaths. during this period. And the green line is describing all deaths 5-year average per month in the last 5 years. And the red one is essentially describing how much of the mortality that we have seen in recent times has been due to COVID. And you can see a very clear pattern there that when mortality has exceeded the 5-year average, much of it has been driven almost exclusively by COVID mortality. So I think it's a good point to pause and as has been done already, express a lot of sympathy with families that we know have suffered losses of loved ones during this very, very difficult past year as a result of this pandemic. There is clearly a ray of hope in the sense that we now have a vaccine or a set of vaccines and more than 200 million vaccines secured by the government. That means that we have a really good chance of allowing the lockdown to have a sustainable impact, and then as population immunity builds from both natural infection and vaccination, we have a chance of beginning to describe an end game to this pandemic. Chair?
Kelechi, thank you. That was an exceptionally helpful report, which you navigated us through at breakneck speed, but still the messages were very clear. Thank you very much. Colleagues, any particular points anybody wants to raise on that? Ian Wells, thank you.
Yeah, thanks both. And just a quick question. I appreciate we might not have a lot of data for it in our area, but in terms of this inverse testing strategy going forward, is there any merit in targeting BAME communities? And as I say, I appreciate we might not have that data from our area, but when you're applying that to cities, Cardiff, Swansea, Newport, wherever, then that might also have an effect. Yes, you are right that we don't necessarily have direct evidence, but there is indirect evidence that in places where there's greater deprivation, in populations that probably have a higher risk, that's where we had lower uptake. So I think there is indirect evidence to support that, and we will obviously, like I said, later this afternoon we'll be setting out the broad outlines of a plan to carry on with community testing using lateral flow devices in CTM, and we will definitely bear that in mind. Thanks.
Thanks, Ian. And we'll take one more question then before we have a quick break from Maria Thomas.
Yes, thanks, Kelechi. Very interesting to look at the Merthyr and Cynnan testing, and when we did the community testing there, and the positivity rate by deprivation, and the mortality rate, which is disproportionately, to other areas in Wales. To tackle some of these risk factors, should we then be considering going back to the work, and will it help us on the population segmentation that we started right at the beginning of the year before last, to try and tackle some of these population health issues that we've got in our three valleys?
Absolutely, Maria, I completely agree with you, and that is the case. As you know, we started that piece of work and we were in fact, we had secured Welsh government funding in CTM to roll it out to the rest of Wales just in March when the COVID pandemic hit, and that really slowed down things. But the case that we have made to both SAIL and NWIS, who are now going to be crucial in terms of helping us with data to roll it out more widely, is that if we had this completed before COVID, it would have given us a fighting chance of perhaps averting some of this. And it is on that basis that we've got SAIL back on our partnership now, in spite of the fact that they are still busy responding to COVID, but they are working with us, and we're accelerating efforts to get the population health segmentation data for CTM from April, hopefully.
Thank you.
Thanks, Maria. And Kelechi, thank you. A number of comments coming in from colleagues thanking you. Colleagues will know that Kelechi has very affectionately been christened Kelechi the Graph. That is absolutely a compliment. And again, you've demonstrated brilliantly, Kelechi, I think, with a number of graphs I haven't seen before, and I thought I'd seen them all now. that really get the message across exceptionally clearly, which is really helpful. So thank you very much for that. Colleagues, we'll have now just a 5-minute pause before we come back to talk about the vaccination campaign. So according to my watch, it's now 12:16, so we'll reconvene precisely at 12:21. Thank you. Right, colleagues, I think that's 5 minutes. Mike, are we able to continue?
Absolutely.
Just carry on, is it? Yeah, great, thank you. Okay, colleagues, we're back in session. Thank you very much. So we've had the presentation from Kelechi about where we are with COVID, and now we've got the presentation from Claire about what we're going to do about it. So Claire, over to you, vaccination update. Thank you. You're on mute, Claire.
Thank you very much, Chair. So firstly, you'll see that there's an omission in your papers today, and that omission is the number of vaccines that we have provided. I debated whether to include some of the data in the paper today when we submitted it last week, and I concluded that that would not be wise because the pace at which we are delivering vaccines means that every week so far since the programme began, we have been doubling. So before I get into the paper, I just wanted to share some of the headlines with you today, that we have delivered, as of close of play yesterday, 48,956 vaccines across the Morgannwg patch. And that is an enormous testament to the fabulous staff that we have. That's staff, our staff, that's local authority staff, that is volunteers, so retired staff coming back, Red Cross, St John's Ambulance. I could go on with a very endless list. So before I go through into the paper, I just wanted to put my thanks to all of those teams on record, because they are the ones delivering this programme at a scale and a pace that has never been seen in the UK before. So thank you to everyone. If I do get into the paper now, and I will try and run through a few items, and then I'm sure there will be plenty of questions at the end. So the first point that I really wanted to bring us to was on page 5 of the paper, and I think perhaps the diagram in this in the paper helps to explain the approach that we're taking in Morgannwg to delivering the vaccine, and the particular focus for today is around the priority groups 1 to 4. And I know that members may have seen through the comms that are now becoming a weekly feature of the programme, and then our daily updates that we're giving on our vaccine programme. You may have seen this diagram before. What it intends to do is describe the 2 different vaccines that we have available to us in Wales at the moment, and where we would target use of those vaccines, the people in our population who we'd be looking to vaccinate with it, and then the locations and the teams that would be delivering that. And it's really important that we have this high level strategic intent, because it's from this that all of our communication, our planning, our workforce planning, our demand and capacity planning flows. So the diagram outlines that for Pfizer, we're looking to use that for our care home staff and residents, our frontline health and care social workers, and the population over 70. And we're inviting the population of over 70s and our social care workforce into our community vaccination centres. And we are vaccinating our health staff within our district general hospital vaccination centres, and we're using our mobile teams, predominantly made up of our district nursing workforce, but supplemented by many others, to vaccinate in care homes. The other area where we are using Pfizer at the moment is for our inpatients. So all of those inpatients who would fit more normally into a category 1 to 4, we are working through vaccinating those using the Pfizer vaccine. We are then using the Oxford vaccine, and this vaccine is significantly easier to handle and is less restrictive, therefore, with its use. And we're using that into primary care, so that's with our general practice teams, that's with our community teams, and we're exploring how best to take up the offer of community pharmacy to be able to support in these areas. And so we're using the Oxford for the over 80s and the over 75s, and then we're also working through and supporting GPs to be able to vaccinate the clinically extremely vulnerable. So generally that means those who are shielding at the moment and those who are housebound. I would just recognise at that moment that we are supporting GPs. So whilst many of our GPs are taking on that challenge of the housebound and the shielding population themselves, we know that there are practices out there who, because of the scale of their lists and their patient population and the number of partners and GPs they have available, that means it is challenging. So we're putting in place a support process so that we do not miss any of our most vulnerable population for a vaccine. So that's our strategic intent. And as I said, today we will be breaking the 50,000 vaccination barrier. And that's a significant milestone for us because that's halfway to vaccinating all of our priority groups. And we gave ourselves, with Welsh Government, the deadline of Valentine's Day, the deadline of the 14th of February, with which to have completed those the entirety of our population. So that leaves us with a further 3 weeks to vaccinate the remaining half of our population. But given the scale up and the ramp up that we have achieved in the last 3 weeks, we are well on target to achieve that. Within that target of the 14th of February, there are a few milestones that we've been trying to achieve within that. So by this weekend, we will have achieved vaccination of all of our over 80s. And by this weekend, we will have visited every care home for the elderly across the Cumulative Morgannwg geography and offered every member of staff and every resident a vaccine where they are medically fit and able to do so. And I take a moment to explain that situation because it is important to recognise that whilst we will have been to every care home and been able to visit every care home and we will have vaccinated everyone who is medically fit, because of the level of COVID in a number of our care homes and because of the fitness of the individuals and the residents within it, that means that we won't have vaccinated every single resident. However, we do have a programme that will continue on beyond the deadline of this Sunday, where we will revisit homes as and when people are fit and able to receive a vaccine. So we will keep a continuous programme running for our care homes. I did want to flag just a couple of points. The paper covers off some of the financials and governance arrangements, but I did want to just highlight some of the challenges and the risks that we have with our programme at the moment. I'm sure that board members will be very aware of the challenges of supply across the whole of the UK. This is not local to our health board, Wales, or wider than that. As we must remember that the vaccine, particularly the Oxford vaccine, was only approved for use after Christmas. The following week, we were beginning to put it to vaccinate people with that vaccine. And that's a huge and momentous achievement, really, to have approved a vaccine and then deliver it within 1 week. And actually, we were the first in the UK to use the AstraZeneca vaccine with our GPs. So, you know, some really important and innovative and fast-paced work has led to achieving that. The downside of being so quick off the mark is that supply is fluctuating at the moment, and that means that our planning and the options available to us to be able to deliver that vaccine have to be incredibly agile. And whilst we do have that agility within us and our teams and our programme, it does mean that the communication of those changes is incredibly important. And there have been times in the recent weeks where we haven't been as prompt with our communications and we haven't been able to answer the questions and queries of both the public or particularly our general practice. That is beginning to improve, I'm pleased to say. Our dedicated communication support means that we are getting our messages out much more promptly, and therefore the communications is being able to keep up to the ever-changing position around supply and the ever-changing and the agility of our programme to deliver. The other item that I would flag, and a caveat around all of our numbers that we're presenting at the moment, you know, in a positive way, what I present is a worst case scenario, if you like, because what I'm describing in terms of the vaccinations that we've delivered are those recorded on our WIS system. So there is a dedicated Welsh immunisation system that has been created for this process across primary and secondary care, so available to all, a once for Wales solution, which we are using to record vaccinations. There have been occasions where we haven't updated the system as live, and so there have been occasions where there's a little bit of a lag of perhaps 24 to 48 hours of the vaccinations being recorded on the system. So I did need to flag that to the board. That lag is reducing and improving, and so we are becoming a more real-time system as people grow more confident with using WIS at the point of vaccination. I suspect, Chair, that there are a number of questions from people, so I'm not going to extend my presentation of the paper any further. But hopefully that gives you a neat overview of the huge scale and task that we're undertaking at the moment.
Yeah, thanks very much. Historic times this. We are really breaking new ground, aren't we? Thank you very much for that. I don't know, colleagues, if there are any additional questions. I know that all independent members are brought up to date every week by Claire and Kelechi and Paul. But are there any questions anybody wants to raise on the paper and what's been said so far? I think you've done such a good job, Claire, that there's perhaps just the one question from Nicola. Thank you, Nicola.
Thank you, Chair. Thank you, Claire. I have asked you this question previously, but just for clarification, because there is some social media out there to say we have wasted vaccines, but I don't believe that's the case, Claire, is it? And I think we are very mindful of calling people in at short notice if we get a lot of non-attendance. So just for some clarification around that, Claire, please, if you can.
Yeah, of course, and you're correct, Nicola. The wastage in our health board and actually across Wales is incredibly low. Our neighbours over in England have been asking us how we've managed it. So yeah, I can confirm that our wastage is very, very low. We haven't lost any. We've lost one vial because it was accidentally knocked over. But in terms of doses at the end of the day, very small numbers. We make every effort to be able to put a vaccine into someone's arm rather than waste it.
Thank you very much.
And to reassure also, where we have DNAs beginning to build up, so where we have noticed perhaps that over the course of the day there are going to be a number of vials available, we undertake an assessment of where best to redeploy those so they don't sit in one site potentially going to waste. We have a constant view of where the stock is, and we're trying to agilely move that into where the best need is.
Thank you, Claire. I'm sure that will reassure a lot of people.
Thanks, Claire. Kelechi's just updated us. In fact, less than 1/3% wasted last week, 0.31% last week, which is real testimony. Claire, thank you very much indeed. We're very grateful to you, everything that you and the team are doing, and please carry on, because this is the main hope, isn't it, really, to deal with this very difficult situation. Thank you so much indeed. Okay, colleagues, we're going to move on now, and I'm very conscious of time, but I think some of these items are more straightforward than the items we've been dealing with to date. So the next three under section 6 are all to do with providing high quality evidence-based and accessible care, And Callie, I think you're going to talk to us about the first one, 6.1. We've read the report, so really just anything particular you need to highlight or update us on. Thank you very much.
Thank you, Chair. Yes, just to pull out the key points really from the last update that the board would have received back in November. I'm pleased that before you today you've received a risk management policy that's been updated and revised. We've got the risk management strategy as the next agenda item. So these were key elements of our risk management improvement plan that we've actually achieved earlier to the board in January. We have done a few things again, progress being made since November. We've done a peer review in the estates function, looking at their risks and considering any that may need to be escalated and making sure they're aligned and centralised now with our new approach to the organisational risk register. We've looked in December. I know we said it back in November that we would focus on looking at our trends that perhaps were pretty stagnant on the risk register, and hopefully you can see, although pace due to COVID has sort of impacted that in December, we have updated the organisational risk register as we go along now, and you can see the updates in red that have been made during December and coming into the early months of January. So there is progress on that, and I will continue to work with teams to make sure we look at some of those trends that perhaps haven't moved for a while, and making sure that we've got our mitigation and our control measures accurately on that. I've looked at and reassigned some of the board committees where we think perhaps a lot were sitting with Quality and Safety Committee, just wondering whether they can shift to the other committees. So any changes in that respect are also made in red. I've touched on the risk management improvement plan. We are continuing to make progress. Obviously, the COVID is having a significant impact on our IOG and clinical service group colleagues, and we're able to sort of proactively get in there and review the risks in Dietetics, but we are committed to do that, and I meet monthly with our ILG teams to go through that. We're also continuing to deliver training, albeit in a very remote way, and we've now set up since January monthly risk management training sort of drop-in sessions where IOG and CSG colleagues can drop in and we give them an update on risk management. We talk them through the strategy, we talk them through the data tests, and we talk them through our new escalation process from service to board, and that's been welcomed, and sort of, you know, attendance to that has been good, and people are welcoming those sessions continuing, and that's actually involved colleagues being able to feed back to me in those sessions on improvements that we can make to the strategy and the policy, which has been really helpful. So onto the risk register, we've added 4 new risks this period. I think independent members, colleagues will be pleased to see that the ambulance transfer risk is on there. I know that was one that we've discussed recently in Quality and Safety Committee, and that's obviously been added to our organisational risk register this time. We've de-escalated a number of risks as well, and we've also closed some risks where they perhaps amalgamated more effectively into one risk rather than having 4 separate risks on the risk register. So there has been some improvement done. George alluded to the internal audit report that we've had. We had a review being done in November, December time, linking in with myself and colleagues across the organisation heavily involved in risk, and we've had an overall really positive report in there. I was pleased that they noted the significant improvement we've made over the last 12 months, as well as recognising some improvements that we still needed to do, which actually were reflected on our risk management improvement plan anyhow. So I think that was reassuring to know that we were in the right direction. Those are the key points I wanted to make, Chair. Obviously the risks are not my risks, there are our colleagues' risks as well, so if there's any specific questions on the risks, then I'll direct those to my executive leads, but other than that, Chair, I think everybody's had an opportunity to read it and review, so thank you very much.
Thanks, Callie, that's very helpful. Ian, we come to you first. Ian Wells.
Yeah, thanks, Callie. I just like to say, first of all, this is really massive improvement, and you can see things really improving every time we look at this. And the problem, of course, is when you improve something, you previously, I suppose, the phrase I would have used is you can't see the wood for the trees, but we can see that now. We can see where the issues are, and it's highlighted some worries to me. And I know there's a few risks which have been highlighted, which are still at 20. And are flatlined, so to speak. They have moved for a number of years in some cases, and I suppose I know you're doing a lot of work on this, and I just wanted to point them out, and I'm sure you're aware of them. because I think we should remind ourselves of them every time we see them.
Yes, thank you, Ian. Just to reassure you, we are acutely aware of that, and that's one of the things that we're pushing through December, and we did do on some of them, but obviously there's some work that I need to do with our ILG colleagues when the focus on their clinical operational focus perhaps has eased a little bit around COVID, that we can really get into these. And one of the things we are looking at, again, what worries me when perhaps the trend is quite stagnant is have we got our control measures and our mitigation action correct? And that's one of the things that we're actively reviewing. So I appreciate it. It may take us a few meetings to get that where we need to be, but it is something that is very much on our work programme to do.
Yeah, definitely in the right direction, I think.
Thank you, Ian.
Thanks, Ian. Jane, we come to you next. Jane Sackgrove.
Thank you, Chair. I will echo the comments that Ian's just made about the real improvements in the risk register. It is much more user-friendly, and I think it really is surfacing the risks. I've got a very specific question to ask, and I'm not entirely sure who can answer it for me. On page 16, there's a very welcome piece of progress on telecommunications upgrade. Clearly, telecom's very important, particularly at a time when people can't come and visit. And we know from the Quality and Safety Committee that this has been a long-standing issue. So I'm really, really pleased to read that there is progress being made. The narrative talks about the contracts that are out to tender covering 2 of our 3 hospitals. And my question is whether the telecom system in Bridgend is already acceptable, and whether the system that we're proposing to implement in the other 2 hospitals is going to be compatible with the Bridgend system, or are we going to have to do something about that later?
Thank you, Jane. I may divert that question to either Claire Williams as our exec lead for ICT, or maybe even Gareth Robinson. So if I may divert that question to them. Thank you.
Hi, Jane.
Hi, Claire.
Hi, Jane. Sorry, I was waiting for the camera to switch off. Apologies. Really valid points. I don't know the answer off the top of my head. I would be assuming that there is compatibility in the systems. That is what we're striving to with all of the decisions that we take to make sure there is compatibility. But I don't know specifically on this system. So perhaps I can take that one away, Jane, and just reconfirm to you. But in principle, the answer would be yes.
Lovely. Thank you, Claire.
Thanks, Claire. Good. Colleagues, I can't see any more questions. So on this item, we're asked to note the progress that's been made, which we do, and we're very, very pleased on that, I think, really. And also to approve the recommendations in relation to new risks, de-escalated, upgraded and closed risks. Yes, colleagues, I think we're happy to do both of those. Good, great, that's super. Thanks, Callie, that's great. And I think you're going to talk to us about 6.2 as well, the risk management strategy.
Yes, thank you, Chair. And again, I don't intend to spend too long on this item. It was an item that we shared at the December Audit and Risk Committee, and they endorsed approval to the board for that. Obviously, it falls within the remit of the Audit and Risk Committee to sort of review and endorse the risk management strategy on behalf of the board. I think some key things just to update on is within the strategy, we've really reflected the work that we've done in the last 9 months, not only with board around our principal risks, but also around the work I've been doing with our ILG and clinical service group colleagues about making sure the risk domain matrix and our process for assessing risk and our grading makes sense and is applicable in the service so that it works for them. And so there's some redefined risk matrix domains within this updated risk management strategy that I'm hoping works a bit better for the organisation and that service to board escalation. And I have assured colleagues across the ILGs and clinical service groups that if where they feel things of the strategy perhaps aren't working, that we will reflect it and review, and I can bring it back to board for a further iteration. So I just wanted to say it's a significant review reflecting the progress that we've made. it reflects some work we still need to do this on the risk management improvement plan around the board assurance framework, but obviously I think this is more reflective of the position we are now in with our organisational risk register and the approach we're taking in respect of risk. So that's all I wanted to say, Chair. Thank you.
Thanks, Kelly. That's great. Colleagues, any questions or comments anybody wants to make? I'm just looking at the chat bar to see if anybody wants to particularly to come in. If not, Kelly, thank you for both of these items, really. As Ian said just now, we're starting to see the woods for the trees. We're starting to be able to use these crucial sets of information that we can't do our job without, really. So it's really encouraging to see the improvements being made, and we note there's still a little way to go, isn't there? And we all acknowledge that. But we're making good progress, and many thanks to you for being instrumental in that. So
thank you, Chair.
Thanks very much. And then we move on to item 6.3, the integrated performance dashboard. Again, Claire, we probably we don't need to go over the detail of this that's covered in the paper, because I'm sure people will have pored over that with considerable interest. But is there anything, Claire, that you wanted to particularly bring out or to update us on?
Thank you, Chair. I shan't go through the detail of the paper as ever. It's presented there for posing questions really from the board, and I'm sure that some will come forward. Really, I just wanted to flag that we have included some detail on WISC in this performance dashboard. In the cover report. I know that it's been an area of particular concern for members over the course of the last 6 months or so, and as the paper explains, the information flows from partners and through WISC has been challenging through the COVID period, but they are beginning to be reinstated, and so there's some detail there around our position with regards to our population who are sitting waiting for that specialist surgery. It paints a picture that I suspect we would have envisaged, and it is not dissimilar, unfortunately, to our secondary care services in terms of unfortunately people waiting longer than we would have envisaged or hoped. But to reassure the board, now that the information flows are continuing, we will continue to keep the board appraised of the situation through the performance report, and we will be escalating concerns and working with partners through WISC to try to ensure that these pathways are opened up as quickly as possible.
Great, thank you, Claire. That's very helpful. A couple of questions coming in from Maria, first of all. Maria Thomas.
A very comprehensive report and tells us exactly what the mitigations are in respect to some of the issues that you've raised. Can I take you to page 7, and can I take you to 2.22? Yes, 2.22. It's about the elective activity, and then if I could just refer to the capacity within the private sector and the reduction down in that capacity. Is there a reason for that? Because we were using them quite frequently, weren't we?
Yeah, so I'm going to defer to Gareth. I know that he's new coming in, but he has been, as you can imagine, trying to get up to speed in terms of our elective delivery as quickly as possible. I suspect there are some challenges in terms of private sector availability over the Christmas period, but Gareth might be able to come in on that.
Yeah, thanks, Claire, and thank you for the question, Maria. It's exactly as Claire's described. The two factors around the capacity that the private sector are making available to us and the impact of the winter period has depressed the availability of capacity over the course of the last 4 weeks. What I might do, with your permission, is just describe some work that we're doing around the elective restart plan, which is probably more material to how we address the significant backlogs that we're generating, rather than just focus on the private sector, if that would be helpful.
Yeah, please do, Gareth, that'd be good.
Okay. So again, cognizant of the fact that I'm relatively new, so I won't give the whole background on why we are where we are and the position we're in. I'll just move to what's going to come in the future. We cognizant of all of the elective backlog, which is consistent with the whole of Wales and in fact the whole of the UK. And over the course of the last couple of days, we've been working closely with the integrated locality groups. Try not to use the term ILG, with the integrated locality groups and our colleagues within the operational teams to build a planned care recovery programme, which is going to have three aspects to it. The first one, and gratifyingly yesterday in Gold, we made the decision to restart services in a planned, careful and considered fashion in the elective area, working with the ILGs to build those up in terms of the immediate next few weeks and months. There's a second aspect where we will be building a plan for the next 12 months, which will have some clear trajectories that the board will be able to monitor us against in terms of what available capacity we have and we can control now. How can we maximise the restarting of elective services and care for as many patients as possible within our existing capacity? And in parallel with that, develop a more medium and long-term plan, which may involve the kind of reconfiguration of elective services, which would allow us to get maximum efficiency and capacity in the system, and build a plan that kind of helps us map out how we recover from the significant problem that we've got. I would expect that plan to be developed over the course of the next 4 to 8 weeks and bring that back in greater detail for the health board to review. But it's a significant programme of work, and the language that I'm using is that the reset of the elective activity is arguably as material as high pressure as dealing with the COVID pandemic over the course of the last 11 months.
Thank you, that's helpful. Thank you.
Thanks, Gareth, and I think we would all echo that last remark. We're all being very, very conscious of the growing problem that we've got, and a welcome, by the way, to the board. I think this is probably the first time that you've spoken to the board. So lovely to see you. Thank you very much.
Thank you, Marcus.
And then we've got a comment and a question from Nicola Milligan.
Thank you, Chair. Thank you both. Thank you, Claire, for that report. Claire, I have a comment and a question, if I may, please. My comment, and we keep using COVID as a reason sometimes why we've delayed things, but my comment is around the return to work compliance, which has dropped yet again. And I think in these current situations, a return to work is even more important for our staff. You know, it helps for us to dig into any support we can offer them to maintain their return. So I'm a little bit disappointed that we just, I mean, it's a poor compliance rate, but it just constantly seems to be dropping. So that's my comment, Claire. And then my question then is on page 10. And it's 2.43. And it's in regard to the extra clinics we've been running. Have we been sure that we've seen the 3 that were waiting over the amount of time they should have been? Have you got it there?
Yeah, Nick, sorry, I'm on page 10.
2.43.
Okay, yeah.
So for the 26-week target, we've got 3 that were waiting a maximum of 87 weeks. I'm just wondering, have we been sure those 3 have been seen in the waiting list initiative we've been running?
So unfortunately, Nicola, I don't have that level of detail with me at the moment, but I have no doubt that we'd be able to provide you with the detail around those 3 individuals. The direction would have been to have treated those longest waits first. That's the whole principle behind putting the waiting list initiatives in place. But I couldn't tell you that definitively now. So if it's okay, between Gareth and myself, we'll come back.
I see Nick is offering to come in on that point. Can you help us on that, Nick?
Very happy. Thanks, Nicola. I can confirm that 2 out of the 3 certainly have, and there are concrete plans for the 3rd. I think the discussion there is about the most appropriate because it may need to be seen by a slightly different route, but the clinical teams are absolutely on it.
Great. Thank you very much. Thank you, Nick. Thank you, Claire.
Thanks very much. That's very helpful. Colleagues, I can't see any more contributions from people. So Claire and colleagues, thank you very much indeed. Very helpful. Very concerning, obviously, because of the scale of the tasks we face, but thank you very much. And Claire, I think you are going to take us through the next one as well, aren't you? 7.1, which is the Integrated Medium-Term Plan Progress Report. Again, Claire, we've read the report. So anything specific that you need to draw to our attention?
Thank you, Chair. Nothing specific at this point. I suppose what this paper is produced at a point where planning is at its most challenging it has ever been in the NHS in terms of medium to long-term planning. I think I have said this in my career for the last 3 years on a row. This is the hardest planning cycle I've ever been involved with the Bridgend boundary change, and then and one thing and another. But genuinely, I hope that I never have to say this again, because it has been and it will be the hardest context in which we are trying to develop this year a 1-year plan, not a 3-year plan, as directed by Welsh Government, that we have ever achieved. So I just wanted to ensure that the board were cited on the complexities and the challenges. I wanted to make sure that they understood that we are doing all that we can to produce the skeleton of a plan, and that we within our corporate teams, which we will then take to our clinical teams, our ILGs, to help us flesh out and make final decisions. We felt that that was the best way to try to develop the plan this year, so that our clinical colleague could focus on over the Christmas period and these coming weeks on a COVID position. So we have a number of actions that we will be taking through February and then in the first weeks of March to try to pull together and have available to the board in March an IMTP that you will be able to sign off. Clearly, from a workforce and finance perspective, that ability to understand where our services are going for next year means that our workforce and financial planning, which always follows, is really, really very difficult. And I'm just going to pause before we complete this to bring in Steve, if that's okay, just to give his perspective from a financial planning. But my final point would be that we will make sure that we keep the board abreast through our board development sessions and other communication as to how we're progressing with the IMTP, because clearly we've got a very short time scale now and we need the board to be cited on how it's developing before March.
Steve?
Yes, thanks, Marcus and Claire. Yeah, I think we will develop the financial plan in sort of 3 sections. I think a core plan, which will be like a sort of normal plan, if you like, and then a COVID response plan, and then planned care recovery. As Gareth was saying, and the planned care recovery bit is going to be important. The bit I just wanted to alert the board to, and it's covered in the report, but that's some of the implications of the allocation that we have from the Welsh Government, because it is pretty much the sort of allocation that we would get in a normal year, setting aside COVID and setting aside planned care recovery. So that has quite an implication for us, in the sense that it's what we would have expected for 21-22 pre-COVID, but in our 3-year plan, where this would have been the 2nd year, we would have been spending 2021 developing our capability around Cumulative improvement and value-based healthcare and a number of other enablers that would help us with 21-22, which was always going to be a year of higher savings because of the recurrent deficit we imported from Bridgend and for other reasons. So instead of having an enabling year for a more challenging year with more change, of course, we've had a year where we've been focused, on COVID, and so that enabling work has not been able to be done. And more challenging than that, of course, we've not really delivered significant savings in the current year because of the focus on COVID. So we've sort of got a higher savings requirement and a catch up from the current financial year. So really that means that within the allocations that Welsh Government have given us, the level of savings we would need to deliver to achieve break even is just not going to be feasible. It's very highly unlikely to be feasible. So I think there are two implications of that, really. One is an interaction with Welsh Government about that situation, which we have started, that we're going to need some akin to bridging support that we were talking about for the previous year, but more so. But I think the other implication is that while we're seeking some form of bridging support, it makes it more challenging to be planning any significant further internal investment while asking for bridging support for the core. So I think there's a number of challenges in that particular position, which won't be challenges just for Cumtaf. They'll be shared by many other health boards, but I think there's a particular challenge there, as well as then planning for COVID, as Claire was saying, in the coming year, where it's perhaps in a sense easier to plan for the sort of more proactive things we're doing, like the vaccination programme and ongoing TTP, and harder to plan for the sort of more reactive response that is dependent on levels of COVID that we are unsure about. But also getting into planning for the planned care recovery, and we're really just starting that work, so a lot of challenges there. And while Welsh Government do recognise that is clearly a priority for them, as it is for us, there isn't a clear level of resource in Welsh Government, so there's almost a chicken and egg situation of us developing plans and then testing out what's affordable. So we've sort of got challenges with the core plan, and then more sort of technical challenges or difficulties in planning, as Claire was saying, for the continuing COVID response and for planned care recovery.
Thanks, Steve. Thank you. Questions? Maria Thomas.
Yeah, thanks, Claire, for that. Thanks, Steve. Can I ask you, just as a point of clarification, primary care and their cluster plans and the IMT plans that they will be delivering and developing, will you be including those as part of the ILG plans, or are they going to be separate to those? I'm not quite sure whether I don't want to lose primary care in all of this, you see.
Yeah, thank you, Maria. It's really important, isn't it, that we don't lose primary care within all of this planning cycle. And so as per last year, cluster plans are required prior to completion of health board plans. So the deadline for cluster plans, and again, they are proportionate plans, I think is probably the best way to describe it, is the ask from Welsh Government. So they're being asked to just revisit and update their plan from last year, as opposed to an extensive exercise in planning for primary care. They're due in with Welsh Government by the end of the week, actually, end of January. And so those plans will be part of then what we would see in integrated locality group plans. And as per last year, we will be drawing those plans through as appropriately up into the health board plan.
Thank you for that, because I think it is important, Steve, when we're talking about the financial position as well, and the investment into primary care, that we get all these plans together and look at the financial picture overall.
Thanks, Maria. Any other colleagues wanting to come in? I can't see anybody, so we are asked to note the progress. We're asked to approve the planning guidance and planning assumptions, that's Appendix 2, and to review the other elements as set out there. Can I just check, colleagues, are we happy to do all of that? Yes, I think the answer is yes. In which case, Claire, thank you very much indeed. And we'll move on to 7.2. Steve, over to you.
Thanks, Marcus. Yeah, I can be fairly brief on on the finance report. I think the key point really, and it is a juxtaposition of feast and famine, really. So this year is the feast year. Key thing about the report is that I think we were forecasting a 17 0.1 million surplus. The latest, not the latest focus, the focus in the report is 19.8 million, and that is really coming from an inability, unsurprisingly in many ways, for our teams to deliver on all of the winter plans that they wanted to deliver on. And that, you know, there are recruitment difficulties, there are difficulties in organising recruitment of people that are incredibly busy. So there is slippage against a number of initiatives like that, and that is then coming through in the forecast. And the direction of travel is probably for a higher level of forecast still. So what we need to do now is to try and get to a number that we think we can then hold on and deliver on and feed that back to Welsh Government. The audit concerns around the potential for a prior year adjustment, that's looking less likely. We haven't got to the end of the process with Audit Wales. I think that will go on for a little while, but it's looking less likely that there will be a prior year adjustment. So the key activities now really are to finalise what is our forecast surplus, which will be 19.8 or probably more than that number. Get to a point that we can be clear with Audit Wales, or sufficiently clear that there won't be a prior year adjustment, and then we will need to get a board decision on releasing resources back to the Welsh Government. That will probably need to be done as a chair's decision or a communicated decision. I mean, that is important from a wider Welsh Government perspective, because they are making decisions right across Welsh Government in all sectors, you know, supporting business, local government, so forth. So it is important that we release the resources that we can't use back to Welsh Government so they can be used, and that process is sort of coming to a head. So, you know, in the coming days, couple of weeks, we will have to finalise that number, get board approval for it, and return it to Welsh Government. So that's the key action. But at the same time, trying to get more focus onto next year, which is going to have its challenges, as I was outlining just now.
Steve, thanks very much. Another one of the bizarre things about 2021, isn't it, that we're talking about how much money we're going to give back. Thank you, colleagues. Any questions or comments on any of item 7.2? No, I think that's all. Steve, thank you very much. That's good. So we just simply asked to note the report, which of course we do. Thanks very much, Steve. Colleagues, then we move on. We've taken 7.3 before, so we're on now to 8.1, the Audit and Risk Committee highlight report from the 14th of December. And Ian, I think that there's matters for escalation to the board. Over to you, Ian.
Yeah, there's a few things to bring up. So you can see in the report the things that need to be escalated in the red section. I'll not read them all out because you can see them there, but I think we need to keep an eye on a few things. There are a couple of internal audits that are currently taking place, which are in draft status, and they're going to have limited assurance ratings. So that's in IT service management and data quality. So we're keeping our eye on that for when the full report actually comes out. As well as that, we discussed the review of the audit tracker, and we were concerned in the timeliness of the updates that were taking place within that audit tracker. So that was something that we wanted the executive team to have a look at. So that's something else that was of concern to the committee. There are a number of positive escalation points there as well, which are good news stories, I suppose. We've had a substantial assurance rating in the internal audit review of the PCH redevelopment, which is certainly good news to us. And also the Audit and Risk Committee meeting part 2, WISC recommended also for having closed all their recommendations in the audit tracker, which is also a very good achievement. As I'm not going to read them all out one at a time. I would like to point out to one of the things on the Assure section though, on page 3, and this was where we were talking again about the organisational risk register. That was one of the reasons I brought that up earlier on, in terms of a number of the actions which are staying stagnant. We've noted that at the committee for some time now. I'm glad to say that action is taking place, and as I say, commend Carly on taking that work forward. The other things I think everyone can read themselves, so I won't go through them all. Okay, thanks.
Thanks, Ian. That's very, very helpful. I'm just looking. Then there's no questions or comments coming in from colleagues, so thanks, Ian, for that. Oh, sorry, George wanted to make a comment. Yeah.
Sorry, thank you both. Thank you, Ian. I think it's probably just worth noting that certainly under one of the areas that's been escalated for board is around the audit tracker. And colleagues both from internal audit and external audit have kindly agreed to work with us, and we've got a series of meetings with each of the executive leads throughout February and March. So there's every intention that we will have a thorough review of all of that and clear as many as we possibly can. So I just wanted to provide that assurance.
Excellent.
Thank you.
Thanks, George. That's great. So colleagues were asked to note the report, which of course we do. Thank you, Ian. And then similar sort of thing in relation to Planning, Performance and Finance Committee report. Mel, there's some things you want to highlight to the board there as well.
Yeah, thank you, Chair. Just as Ian said, I'm not going to go through the full list there, but there were two particular issues. One which I suppose Steve has just covered in his update on the financial issue. It was something we just wanted to bring to the board's attention at the time. That was back in December in relation to the monthly finance report. But Steve has just about clarified it, because as with finance, they seem to change day by day by day. So Steve has just given us an up-to-date version of that one. But there was one other issue that we thought, and it's actually been referred now to Quality and Safety Committee. The committee discussed the current waiting times. This is going back to December, of course, but I don't think nothing has changed, having just read the performance dashboard. The waiting times for the neurodevelopmental services as part of the integrated performance dashboard, which we just discussed. And we did feel concerned about the length of time that some patients were waiting for assessments and prioritisation, fully understanding the dynamics that were going on and COVID and etc. But we felt that in all those figures, there were people waiting for assessment and for treatment and for prioritisation. So just to ensure that people were cited, we brought it to the board's attention today, but of course we have referred the issue for the attention of the Quality and Safety Committee. I won't go on about the others there. We've got advisory issues there, and as you can see, and we've got assurance issues, a full list of what we looked at and things that we were assured about. But in relation to the escalation and the alerts, I think it was the integrated performance dashboard issue in relation to the neurodevelopmental services, which I've just outlined as well, the one thing we bring to the board's attention. Thank you, Chair.
Thanks, Mel. That's very helpful. These reports, I think, are really good at ensuring that the whole board is cited on the issues which are being discussed in different committees, because nobody is a member of all the committees. So thank you very much for that, Mel. That's very helpful. Colleagues, any particular comments or observations or questions on that? I don't think so. That's great. Thank you. So we're asked to note the report, which of course we do. Item 9 then is any other business. There was just one item just to mention in terms of our governance in this COVID period. So just to remind members that Chair's urgent action was taken to continue with the current stand down situation in terms of our meetings until the end of next month, end of February, with a view to recommencing committees from the start of March. The exception to that, of course, is quality and safety and audit and risk, which have continued. George, anything else you wanted to say in relation to that?
Thank you, Chair. Yeah, so you'll recall in the original request for support from the board that it was left down to Chair, Chief Executive and myself to have a discussion around mid-January to see whether it should be extended into February, which we did, and we have communicated that to the board since. And I just think it's probably timely just to report that We did have a board scheduled for February because in the absence of other committees taking place, we felt it important to have monthly board meetings, but we've reviewed the business that's likely to come up and instead agreed between the Chair, Chief Executive and the Chair of the Planning, Performance and Finance Committee that we will hold a Planning, Performance and Finance Committee towards the end of February, specifically to focus on performance. We're having board development session where we will be looking at the development of strategy, which we've alluded to earlier in the meeting, and then I would therefore suggest that in line with the process agreed by the board of reviewing this, that the Chair, Chief Exec and myself review this again in a couple of weeks' time to make sure that we are in a suitable position to reinstate the committees from the beginning of March.
Thanks, George. Colleagues happy with that? I'm relying on people to say no if they're not, otherwise silence is assent. Thank you. Thanks very much, George. So item 10, date and time of our next meeting. The next formal public meeting will be held in 2 months' time on Thursday, the 25th of March, 2021. So colleagues, that concludes the meeting. Rydw i'n dod ar gyfarfod o'r Bwrdd Iechyd I Ben. Thank you. I'll now bring the board meeting to a close and extend a thanks to all those who've taken the time out to join and observe us today. Thank you all very much indeed. Take care now and look after yourselves.